Welcome back to Data Science to Power Implementation with Social Determinants of Health. I trust everyone is refreshed and sufficiently caught up on things at the office. We'll begin, as promised, with our afternoon keynote speaker, Dr. Roger Ward. Dr. Ward is the interim provost at the University of Maryland, Baltimore, executive vice president, and dean of UMB's graduate school. I want to tell you that the graduate school, founded in 1918, provides graduate education and training in biomedical, health, and human service sciences. The school offers MS and PhD programs and also dual degrees with some of our professional schools, including PhD MD, PhD PharmD, and PhD DDS degree programs. Please welcome your afternoon keynote, Dr. Roger Ward.
Thank you, Alex. It's a pleasure to be here, and allow me a couple seconds to share my screen. Again, thank you all for allowing me to join you this afternoon. I don't know whether it's better or worse to present a keynote before lunch or after lunch. But I'm going to go with before lunch. So in the time I have, I wanted to focus in on perhaps, I've reviewed the agenda, obviously, and I listened in to Dr. Gerald's keynote this morning, and he was gracious enough to share it with me. But I want to bring a little bit of a different perspective, given my role here at the university, to the conversation surrounding data science. As Alex mentioned, one of the roles I have here is that of the dean of the graduate school. So obviously, I'm very interested in data science, and use it in our work and in the ways in which we educate students. But one of my principal roles is that of the provost. And of course, all of you, especially those of you who work in academia, understand what the role of the provost is as the chief academic officer. But my principal role, one of my principal roles, as I see it, and as it relates to the use of data science, is that as the university's chief strategy officer. At UMB, I'm responsible for strategy at the university and overseeing our strategic plans. And I'll get to that in a little bit. But who knew that in getting prepared for my presentation, I came across this interesting tidbit that from the Harvard Business Review, that the sexiest job in the 21st century is that of the data scientist. And that came as news to me, but when I stepped back and reflected, and it makes sense as to why that is, and therefore why so many people are flocking to this very important field, this very important profession. A little bit about my background as well. I'm trained as an attorney. Along the way, after that, I went on and I earned my doctorate. I'm an educator in education. I'm a higher education, in higher education management in particular. But my first degree actually was in computer programming and data processing. And so I've always been very interested in data, the way data is harnessed to inform decision making. And later on, I also went on to earn a Master of Science in Law with a focus in cybersecurity law. And I actually teach in that space, and in particular in cybersecurity law with a policy focus. So there too, I've always been engaged and focused on data and the use of data, and especially as it relates to decision making, but also the policy and legal implications of how we harness and use data. And I've long been influenced. I'm putting up, in the interest of full disclosure, some of my influences here as it relates to the way I relate to data science and how I think about the data scientists. And some of these folks are featured here: McAfee and Bryn Jacobson, who've written for the Harvard Business Review publication I read frequently. And then there's this guy, Alex Gastrunis, who has a very interesting YouTube channel. And yes, I'm young enough to be hip enough to be plugged into the YouTube era where he deals with a lot of stuff on artificial intelligence. So I thought I would harness what I've learned from these folks and how they've influenced my thinking on data science to sort of like frame my comments today. So one of the lessons, and this is from McAfee in particular, that he teaches is that there's both from the point of view of big data for executives like myself and strategists like myself at the institutional level, that there's both an opportunity and a challenge. And the opportunity is that smart leaders, and I think I'm one of them, I'm hoping I'm one of them, across multiple industries, including higher education, of course, will see the value of using big data and embrace it as a management revolution. The challenge, however, is that becoming, and which is what we strive to be here at the university, what he calls a data-enabled organization, is an enormous undertaking and at times forbidding undertaking and requires hands-on, but also that balance between a hands-on approach, leadership approach, and a hands-off leadership approach. And I'll come back to that in a minute. So as the individual responsible for helping to curate, craft, implement university strategic plan, and I'm in my third cycle of engaging in strategic planning at the university as we speak, we always start with our mission. And I'm always focused as the provost, and before that as the university's chief operating officer, on our mission and our vision. And you see them stated here, and simply stated, our mission is to improve the human condition. And that, of course, involves all the challenges that we deal with as human beings, including those having to do with the social determinants of health, but also HIV, AIDS, cancer, and all of it. We are obviously a health and human services campus. And you see our mission here as well. And so we always start with that. And I certainly, in everything I do, in terms of leading strategic thinking, start with our mission. What are we about? What are we trying to accomplish? And what are the tools available to us to get us to the point where we could accomplish our mission, or at least get close? And I have found that adopting a data scientist mindset is helpful. Now, I'm not claiming to be a data scientist. I'm absolutely not that. But I have long appreciated and valued certain attributes that good, what I call strategic data scientists possess, that I have employed in the strategic planning process. And I draw on lessons that I've learned from the data scientists and the data science field to help shape our strategic planning process. And I'll talk about the ways I do that in a little while. But from my point of view, these three attributes for me are key for what I consider, or who I consider to be a strategic data scientist. Someone who has obviously the training and the curiosity to make discoveries using big data. The professional who could leverage existing data and create new ones to deliver information and actionable insights, because at my level, as an executive here at the institution, we're leveraging information to make decisions. And the third one, I would argue, is the most elusive, capable of articulating to decision makers like myself, to the president, like the deans, how the insights that these data scientists have extracted or uncovered in big data can be used to drive business decisions so that we could achieve our strategic goals. And this is where I find this attribute of these three, for me, oftentimes are the hardest to come by, which is what I believe contributes then to the disconnect between the work, the very important work that data scientists do, and how that work then gets capitalized, leveraged, and used by the institution to achieve strategic goals. And I'll come back to that as well. So again, McAfee and others talk about the pillars of expertise, and as it relates to the data scientists. And you see the four laid out here. Obviously, other people have other perspectives on what these pillars could be or what these domains could be, but you have the business, math, computer science, and communication domains. I present these now because I want to make a point about them later on, coming back to that third elusive attribute that I just mentioned. What we focus on in our strategic planning process is using data to make informed decisions so we could get out of our strategic objectives. And so while certainly on our campuses, we have people with the expertise, the data, the ability to probe that data, what we work hard at and what we've been working very hard at is trying to connect those people with the senior executive team. So we have the data scientists, expertise, we have their work product, and we use that to help inform the decisions we make, to validate the strategies we adopt, and to measure the successes we're having. So it's connecting the data scientist with the senior executive. And throughout the process, there are several lessons, five or six that I have come to rely on. And again, drawn frankly from the big data literature and the data science literature. Lesson number one, you can't manage what you can't measure is how it's actually stated. I sort of rewrote it a little bit to say you can't achieve what you don't measure. And why is that important? Well, that's important, and you see this process model for those of you who are really the true data scientists. This model is probably familiar to you because it's a model, a data process model used by data scientists. We have adapted that model to create the strategic planning cycle model that we currently use, that we use in the last strategic planning process and that we use in the current planning process. And what the model does, it allows us to continue evaluate the decisions that we have made, measure how we are performing relative to those decisions, revisiting those decisions with updated information, and iterating as we go throughout the planning process. And for us, the planning process is 5 years. And so if we are truly trying to achieve our strategic priorities, we don't just set goals and say, these are the goals we have adopted back in March 2016 or whenever it was, we adopted our goals for our current strategic plan, and not revisit those goals, not update those goals, not assess how we're performing relative to meeting the objectives we set about. We continue to evaluate our performance. Lesson number two, mute the hippo. There's a tendency in organizations, and then certainly with people who hold positions like mine, to where, and in fact, others sort of defer to the leader. So the hippo, of course, stands for the highest paid person's opinion. And there's this concept that says, resist making decisions by relying on the hippo, the person who gets paid the most and with whom the buck stops, which is obviously at the university setting, is the president. Though the president isn't always the right person, nor is the provost, or sometimes nor the dean the right person to be making that decision. And so that's another principle that as a strategist, I adhere to. And so how does that show up in our strategic plan? It shows up in the way we set up the outcomes in our strategic plan. You see, we set themes, we set strategic objectives, we set strategic outcomes, but where the rubber meets the road is at the school and administrative units, where they set the specific goals that will tie back to the broader strategic priorities that the institution is trying to accomplish over the strategic planning cycle. And again, these priorities involve the health and welfare of the West Baltimore community, our global health priorities, our social justice priorities as it relates to our School of Law and our School of Social Work, all these things that feed in and are factors when we talk about the social determinants of health. And so we try to co-locate the data because it's our School of Social Work, it's our School of Medicine, it's our School of Pharmacy that operate at the level of where we're trying to have impact in terms of our community. And that's where the data is generated. That's where the research is generated. So we try to co-locate decision-making by the Dan Mullins in the School of Pharmacy, or by the Wendy Shires in the School of Social Work, the SWACO's program, where the rubber meets the road. And that's how we get to operationalize and animate our big, bold goals and ambitions. Now, of course, you always have to guard against this idea that if I didn't generate the data, it can't be useful to me. One of the positive attributes of big data is that, and certainly in this day and age, data moves quickly, it's transferable. So we encourage the moving of data, notwithstanding where it was generated, where it was processed initially to places where it could be useful in the decision-making process. And we encourage decision makers to embrace the data, notwithstanding the source of its generation. And so when we ask our leaders where the rubber meets the road to set goals, this is the construct that we ask them to use. We use this SMART approach. The goals have to be specific, they have to be measurable, they have to be attainable, realistic, and timely. And again, all of this needs to be measurable, and we ask them to evaluate the goals against the best data and information they have, relying on the expertise of the people in their areas, like data scientists, who could generate the information necessary to make these decisions, to craft these goals. Another lesson for me as a strategy person is when you empower folks to make decisions at the appropriate level, using data at the appropriate level, you have to ask a lot of questions along the way to hold people accountability. So that's the trade-off. Decision-making discretion, using best data, using intelligence, but then being held accountable by asking important questions. And that's the responsibility of the chief executive or a senior executive. What do the data say? Where did the data come from? What kind of analyses were conducted? How confident are we, or should we be in the results? Because decisions have consequences, obviously, in terms of the people you employ, the number of people, the amount of time people invest in pursuing an objective, and of course, in how we allocate resources. So it's imperative that we are asking these types of questions. And herein comes a little bit of the challenge as it comes for someone in my role. I mentioned these 4 domains and these 4 pillars before. What I tend to see is this. Experts, data scientists steeped in these 2 particular pillars, and they end up talking a lot to themselves, and the information they provide, the data they provide, they could make sense of. But the executive at the next level who needs to use the data, and very useful data, by the way, to make decisions, can't quite understand because they don't possess these at the same level of expertise, these 2 domains. The understanding the business context in which the data has to be used, in our case as a university trying to improve the human condition, and how to speak in lay terms to leaders so that they could communicate what the data said, why the data is important. So that communication pillar is also very also very important. And then the next to last lesson is I always allow myself to be publicly overruled by the data. I have ideas, I have assumptions about things, but I empower my team as a part of the decision-making process, as a part of the strategy-making process to probe the data, gather data, seek the data out. And if it turns out that the data contradicts a hunch I may have, a thought about how we might be able to approach something, I allow myself to publicly, as I say here, be overruled by the data. That empowers, I have found over time, it empowers people to understand that that is exactly what we want them to do. We want them to rely on the data as opposed to their gut and their hunch, especially when the stakes are very high. And then, of course, the final lesson that I've learned along the way as the chief strategist here at the university is data is better. And by that, I mean data-driven decisions tend to be better decisions. And leaders who refuse to embrace this fact, of course, will eventually be replaced by others who do. You can't be successful in this environment where there is so much risk to every decision that we make that you don't seek to use data and rely on data and embrace data in a compelling and effective way. And it's around this whole idea of data is better that we have constructed our enterprise risk management program at the university, which in sum basically is the process we use to identify the risk in the environment that might prevent us from achieving our strategic priorities. So to recap, you can't achieve what you don't measure. And of course, we depending on our data science community to help us with that. We have to mute our hippos, our highest paid officials here at the university, and change the culture where people tend to defer to them on everything, even when the data might suggest something else, and we co-locate data with decision making, ask those difficult questions, embrace the idea that you could be wrong, that you could be overruled, and data in general is better for us. I wish I had a whole lot more time to go into it, but it's after lunch. You have a full, robust agenda, and I just wanted to take the time to leave the strategist point of view with you as you engage in your conversations as experts in those 4 domains that I spoke about. That for me, what's the purpose of data if it can be used to drive institutional strategy? And I'm hoping that as data scientists, you find ways in which to make that data more accessible to leaders like myself in the strategic planning process. So thank you for your time.
Dr. Ward, if you will stop sharing. And I'm going to exercise caution when I in future call someone in the upper levels of the university a hippo. So I have to be very careful about it. But thank you. That was a wonderful talk. Let me just do one thing here. Sorry. Okay, there we go. I want to introduce the panel for the 3rd session of today's conference. The title is Bridging the Disparities Gap in Data. And they are Dr. Esther Villalonga Olives from the University of Maryland School of Pharmacy, Dr. Jay Craddock from the University of Maryland School of Social Work, and Dr. Tim Oates from the University of Maryland, Baltimore County. We're going to reserve Q&A to the end of the session. Joining us to engender discussion and engaging Q&A at that time will be Dr. Daryl Gaskin, Director of the Johns Hopkins University Center for Health Disparities Solutions. You can write your questions at any time using the Q&A function on your screen. Panelists for this session You can please turn your cameras on and be ready to unmute your mics when the time is right. Our first panelist will make her presentation by video. There she is. Dr. Esther Villalonga Olives, thank you, is an assistant professor in the Department of Pharmaceutical Health Services Research at the University of Maryland School of Pharmacy. She's a social epidemiologist and an expert in the process of adaptation and development of patient-reported outcomes. Her current work focuses on the analysis of social capital as a determinant for several health-related outcomes. Her current work is also focused on the adaptation of instruments to measure health literacy and cancer knowledge in Hispanics, and she has used modern psychometric techniques to validate an instrument she has developed to evaluate bridging social capital. Dr. Villalonga Olives' presentation is entitled Social Capital Disparities.
Hello, good afternoon. I'm Esther Villalonga Olives. I'm an assistant professor at the Pharmaceutical Health Services Research Department at the School of Pharmacy at UMB, and the title of my presentation is Social Capital Disparities. I'm recording this presentation because I'm giving a keynote in another conference, and it's too bad that they are happening at the same time, same day. But I'll be happy to answer any questions, comments, critiques, suggestions you may have. So I give you my email at the end of the presentation. First of all, my overall objective is for you to reflect at the end of my presentation on the value of social capital in public health response to achieve a desirable public health outcome. Importantly, let's define social capital first. Social capital, Robert Putnam defined social capital time ago as the behavior of social networks and relationships characterized by the qualitative presence of enhanced trust and reciprocity. Social capital can be part of the individual, but can be part of the collective as well. Group social capital. When I talk about group social capital, thinking about a collective or a group. So I think about a job place, or a neighborhood, or a community. And I think about this community having social capital. They have social support, they have information channels, social cohesion, and norms. Social capital is a determinant of health, social determinant of health. And here you have in red that as part of the social determinants of health, we have social and community context, and social capital plays a role here. It's one of the factors that are part of social and community context. The social determinants of health are the circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. Social relationships at any level can be invested in and form capital that may harvest returns in the future, especially regarding health outcomes. Social capital may benefit members of a community by having like different mechanisms. And these mechanisms involve that social capital positively affects health. So for example, through the diffusion of knowledge on health promotion, or through the maintenance of healthy behavioral norms, or by promoting access to services such as health services, or with psychological processes that provide effective support and mutual respect. So when we think about social capital benefiting members of a community, we think about, well, because there is an encouragement of solidarity, expediting knowledge dissemination, and facilitating the social integration of previously excluded members. And importantly, I have been thinking about the role of social capital during the COVID-19 pandemic a lot, and I believe it has been, and it's still very important. And we have to pay attention to the characteristics of the groups and their social networks, access to resources, behavioral norms, and the use of information when planning an intervention, right? And we have planned many interventions during the COVID-19 pandemic in thinking about the public, in the public health field. And when we think about a public health intervention, it's very, very important to think about the structures of social interaction because they can behave differently. I have a paper that I wrote time ago where I talked about different types of social capital. And what I believe is that things are never simple, of course. And social capital, you can have several types of social capital that I'm going to introduce in a moment that can play, of course, can have different consequences. So first, let's think about bonding, bridging, and linking social capital. And why are they important? To define bonding social capital, when I think about bonding social capital, I think about the connections between individuals who are like you, such as family, relatives, and kindship. So I think about homogeneous groups. When I think about bridging social capital, I think about connections between individuals who are dissimilar or heterogeneous in some sociodemographic sense, for example, such as race or education. But when we think about linking social capital, we think about building trusting relationships across individuals who occupy different positions of power within a social hierarchy. Interestingly, Professor Aldridge from Northeastern University talked about the different roles social capital had, specifically the 3 types of social capital I just mentioned, on the response to a public health threat, or, for example, in the aftermath of a disaster such as the Tokyo earthquake that happened time ago. But he has literature about the role of social capital in the aftermath of Hurricane Katrina, among other disasters. And I thought about investigating the role of different types of social capital of an island, the island of Minorca. Why Minorca? Because I was born there. I know the place very well. It's, as you see in the map, it's a very small island in the middle of the Mediterranean Sea. It's part of Spain, and it lives from tourism. Island nations such as New Zealand, Taiwan, and Iceland have been particularly successful in containing the pandemic. And one obvious advantage is the natural geographic boundaries enabling effective border controls. They also present a potential opportunity to study the role of social capital in responding to the threat of a pandemic. What happened in Minorca was that Minorca was having very bad numbers of COVID-19, so the cumulative incidence was like going up, and very up. And the problem was that the ICU beds were totally collapsed, and the main hospital had to open a new ICU. And the problem was that the hospital had to restrict the outpatient care to open more ICU beds, which was a very difficult situation. And the government announced a total lockdown, so a total lockdown of the full country. And what happened was that the government announced the lockdown on a Friday, but it still left 2 days for people to move a little bit until this was totally implemented. And people were able to move from mainland Spain or from Europe to the island if they wanted to. So when this happened, especially for people that were having second residences, because if you live in a very dense city where there is a lot of infection, probably you believe that if you have a house in an island with a big garden or with better weather, a lockdown is going to be better there than in a smaller place in a city. Interestingly, we thought that we had to, when I say we, I mean, a person from Harvard, Ichiro Kawachi, who has a lot of literature on social capital, and I invited as well Ildefonso Hernández Aguado. He's a colleague from Spain. He's the former director of public health of the entire country, and he's from Minorca as well. So we wanted to investigate if emergent forms of social capital, like such as the creation of networks, or positive or negative sides of social capital, because there can be negative sides of social capital as well. I'm going to talk about this. And we thought that it would be a very interesting case as well, because since it lives from tourism, so if the island lives totally from tourism, closing the boundaries was like a very important decision that would have a lot of consequences for the island. So I conducted individual telephone online qualitative interviews to 25 people between April and June 2020, when people were on strict lockdown. And basically, I was totally concentrated on permanent residents of Menorca in Spain. And since this study was concentrated on social capital during an evolving public health crisis, what we did was to use a dynamic sample recruitment to capture shifting attitudes, concerns, and changes in social capital during the crisis. What I did was to deploy a mix of random sampling and purposive sampling to investigate some like all what I say, emergent topics like new forms of social capital. And here I put some of the questions because what I did was to use qualitative research, because I thought that this was more an exploratory research, so I really needed qualitative methods. And I really feel I have used quantitative methods a lot, but now I use a lot more mixed methods, since I think that it's really important to collect some sort of information, like qualitative information, before running quantitative, to run quantitative studies. So what I did was to use questions like the ones I have here. How has your community changed in terms of organization? Have you observed new forms of solidarity? What do you think of people who are not primary residents of the island, who decided to move to the island from mainland Spain or other parts of Europe after the COVID-19 outbreak? I was very lucky because everybody was at home and had more time than ever and wanted to speak with people. So I was able to speak with 25 different people. And it was good because I ended up with different profiles. So I had frontline workers, many that were more than 80 years old, participants, I mean, not workers, people that were teleworking. So I had different profiles. And I'm not going to show more information about participants here because time is very limited, but I'll be happy to share more information with you if you're interested. So send me an email if you want to hear more about this study. So to give you some examples of quotes, I have to be very brief here, but for example, for bonding social capital. So I got information about bounded solidarity, emergent forms of social capital. There was a person, a nurse who was 47, a female, that was talking about the promotion of local stores and farmers that were selling products online because they had to almost close the business. Nobody was on the street. When I say total lockdown, it means that nobody was allowed to leave the house, only if you had a job that required to be there, but nobody was in the street. And people were allowed to buy some groceries, but absolutely nothing else. And some people weren't, so children, for example, were not allowed to be outside for almost 2 months. So in this case, some people, of course, were very afraid of being outside because they felt very vulnerable. So so the community saw that an opportunity to open like online stores for farmers and local stores that were not using online, that were not having an online business. So, and this person was talking a lot about many changes related to that. So there was a lot of bonding social capital, but at the same time, there were problems, for example, with linking social capital with lack of trust. There was a person, a female who was 74 years old, retired person, that say that the privilege got there. So because, well, they are smart and use their power to get a better life. So it's exactly what I was saying. So I got a lot of these comments about not trusting those that were going to the island when the lockdown was announced. And the problem was that they thought that there was a spread of the virus because they were going from mainland Spain or mainland Europe to the island from places like cities that were having a lot of infection. The same happened when I thought about bridging social capital. When I put this information together, I was observing some intergenerational conflicts as well. Because in this case, there was a policewoman who was 39, a female, that was talking about students or younger adults being super, super irresponsible because, well, they were studying abroad or in Barcelona or in Madrid, and people flew to the island. And some people were mentioning that these younger adults were spreading the virus to other places, and that a lot of people didn't respect the 15-day quarantine that was mandatory. I was very happy to read this comment because it puts many things together of what I just said. So what's the role of social capital when responding to a pandemic like the one we are facing now and we have been facing for a while? So they put together very nice information about when is social capital playing a role and how to use this when we are planning for interventions, like all these interventions or all these measures we have had to implement during the pandemic, like social distancing or vaccination plans. So all these different things. So let me give you some examples. So putting everything together for bonding social capital, when do we need it? Reflecting on the role of social capital, now that I'm conducting, and I cannot spend more time on this because I don't have an hour to talk about this, but now that I'm using the same technique as the one I used for the study in Menorca, now I'm investigating social capital in Maryland and in New York, and I hear a lot about vaccination and vaccination hesitancy. So my results are still preliminary, but they have helped me to understand a bit more like the role or how we can use bonding social capital or bridging social capital or linking social capital when making sure that people are more compliant, or when there is some vaccination hesitancy, how we can reinforce some sorts of social capital or leverage social capital to make sure that we have specific response, a positive one, and we end up with change in behaviors to get more a positive change, I would say, and good health outcomes. So let me tell you that I believe, for example, for bonding social capital, when do we need it? Now that we are in the midst of the vaccination plan, bonding social capital has played a very important role. Those people that were or still are hesitant in getting the vaccine, if they are connected to collectives, groups where all members are getting vaccinated, the likelihood of getting the vaccine is high in those members that are still hesitant, because there can be behavioral social contagion, and the share of information resources that helps in making the decision of getting the vaccine happens. So these can happen. So we want to have this behavioral social contagion. If a person that is hesitant is mixing with those that can convince him or her to get vaccinated. But it's not that simple, because imagine that you are a person or that you have a group of people that is pretty homogeneous and doesn't mix with other groups, or in this case, I'm thinking about a totally different outcome, which is not getting vaccinated, because maybe a group or a collective is not getting the vaccine because they don't have access to resources that are outside of this group. They don't have access to bridging social capital. And there is behavioral social contagion or the share of information that has bad ends. So if everybody's hesitant and if they don't have any sort of bridging social capital, they don't have those bridging connections to access resources and information that can make them to think about vaccination differently. If they don't have that, it's very difficult to expect a change if they are convinced that they shouldn't get the vaccine. So in this case, thinking about this scenario, we need initiatives that aim to build bridging social capital by giving access to resources outside the group to achieve a behavioral change. Types of social capital, the last one, linking social capital. So equally important is the role of linking social capital in ensuring that the needs of the vulnerable are not ignored. In this context, it is vital that individuals can access life-saving health services regardless of their socioeconomic or legal status, cultural identity, or geographic location. A previous study of linking social capital in Spain, again, demonstrated how nurses with low financial resources could be used to increase trusting relationships between irregular migrants and healthcare providers to increase the overall accessibility of healthcare services. With respect to the COVID-19 response, which demands resilience across all levels of the health system, this suggests that the particularly powerful role of linking social capital in extending the accessibility of both general and pandemic-related health services to members of vulnerable or marginalized communities. So my last slide. So when thinking about implementing measures, social capital can play a very important role, right? But first, it's very important to identify the group characteristics and what's the population target if we plan to intervene, if we plan to implement some measures. A social capital-centric public health response is one of the value of social networks in achieving desirable public health outcomes. As concerns over policy compliance, healthcare use, or vaccine hesitancy continue, measures that integrate considerations of bonding, bridging, and linking social capital stand as an immediate available option to reinforce health systems. So as a result, my final message is that it's very important to collect information on social capital to tackle health inequalities. And in addition, when planning interventions, it's super important to think about what's the group, what's our target, what type of social capital does the group have, or the individuals that are part of the group, to make sure that we have a more positive outcome or that we achieve a behavioral change. This is what we are looking for. I have been so happy to be part of this. And again, please send me an email with any question you may have. Thank you so much.
All right, Apurva, if you will stop sharing. I know we all thank Dr. Villalonga-Olives for that presentation. Next, we're going to hear from Dr. Jay Craddock. She's assistant professor with the University of Maryland School of Social Work. She is strongly committed to understanding the impacts of digital technologies on human development and social interaction, and using this work to decrease health disparities and enhance public health social work interventions. Specifically, Dr. Craddock utilizes innovative social network methodology to examine social network dynamics and sexual health-related behaviors, decision-making, communication, knowledge acquisition, service use, and technology to use within networks of young Black adults. Here now with her presentation, Social Network Approaches, is Dr. Jay Craddock.
Thank you for such a great introduction. So I'm Dr. Jay Craddock, and I'm an assistant professor in the School of Social Work at Maryland. And so what I'm going to do today is give you a little information about social network analysis. I'm kind of bridging what Dr. Villa Lianga shared with you about a social capital, and then she talked a little bit about social networks. So I'm going to talk a little bit more about social networks and then bridge it into AI technology, which is the next presentation from Dr. Oates. So I'm pretty much a bridger here, and I'm going to describe a little bit of how we can bridge these different methods to decrease social determinants of health. Oh, next slide. Yes. Okay, so I just realized these are actually, so I'm gonna go ahead. So social network, there's two different types of social network analysis. So social network analysis are, sorry, one moment. So social network analysis, first I'm going to give you a definition, is the examination of differences within social interactions, and then how those differences within or between networks can be associated with outcomes of interest. So we're really looking at how people interact with each other, and then how those interactions influence behaviors, ideas, knowledge, communication. And so there's two different types of social network analyses. One is egocentric networks, where you really focus on the ego, so the individual, and their direct connections to others. So we're looking at, maybe my connection with my friends, my family, my coworkers, and then how those links and how those dyadic relationships influence my own behaviors. The second one is sociocentric networks, which really focuses on the structure of the network. So a set boundary place where we're looking at who is connected to whom within a bounded structure, to see how those connections and those interactions between each individual influences knowledge, decision-making, and behaviors. Go ahead to next slide. So just to give you a little bit more information about the egocentric network. So again, this really focuses on the individual and those social networks, those social network members who are directly linked to that individual. So, going back to the previous presentation where she talked about social capital and social support. So we're really looking at that individual and the type of social capital and the social support they're gaining from people who are directly connected to them. The main goal of egocentric network research is to predict the outcome of the ego. So the person, and that would be your participant or your client. We're really looking at how do these interactions with others impact their own knowledge, their own decision-making, their own behaviors. And things we usually measure in egocentric networks, or one, how ego is connected to the alters. So, what is this a supportive relationship? Is this a non-supportive relationship? Looking at the characteristics of the alter. So is this a friend? Is this a family member? What are their ages? What are their distance, location-wise to this person? How often do they speak to this individual? And is this somebody they feel they can trust? Is this somebody who they communicate with about health? So looking at those different characteristics of that individual, and then also the characteristics of the pattern of those connections. So that might be like going back to how often do they talk to this individual? Is it daily? Is it weekly? Is it monthly? Is this somebody that they have a strong connection with? Is this somebody who we consider a weak tie? So somebody that they know, but they may not talk to or rely on that often. So looking at these different connections to the people they list within their networks, and then how that influences a person's decision, behaviors, and health outcomes. Go ahead, next slide. So sociocentric networks is really, again, it's boundary specific. So sociocentric networks are typically used to examine a boundary specific location. So say like a classroom, a community organization, a city, something very specific with set boundaries. And we're really looking at the structure of the network. And so how the structure of who's connected to whom impacts their either knowledge, their communication, their behaviors. And here is where you kind of look at social contagion, right? So we're looking at how information spread, or how knowledge spreads, or how decision-making spreads within the networks of these individuals. And so again, like I mentioned, the structure here really is what matters within this type of analysis. So we want to understand, based on if you're within the middle or centrally located within the network, are you receiving more or less information than somebody who may be on the outskirts or maybe be isolate within the network? And so looking really at how information and knowledge and behaviors are passed through the network is what we usually use sociocentric networks for. So in my research, I've used both types of networks, and today I'm going to show you a little bit what we can do with both egocentric and sociocentric networks. Next slide. So these are a couple of studies that I've done so far looking at sexual health communication within social networks of young Black women. So one of the studies really looking at how their egocentric networks, so the influence of their network members, who they are, who they trust, who they feel confident with, influence their sexual health communication, and then in the end, their sexual health behavior, decision-making behaviors. Another one looks at the actual structure of the network, so sociocentric network, to understand how we can use these networks to disseminate information within networks of individuals. So disseminating sexual health information, disseminating COVID-related information, and how we can use these different types of modes of communication based on how they're communicating with their network members and those different structures of who they're connecting with within those networks. We can disseminate information or spread information within those networks. Next slide. So the first study I'm going to present to you, it's called Maximizing the Spread of Sexual Health Information in a Multimodal Communication Network of Young Black Women. So I realized actually that these slides that we're presenting aren't my final slides, so there might be some information missing. So I'm going to go ahead and just try to provide you with as much information as I can without the actual visualizations. So I'm going to go ahead to the next slide. So the research goal for this study was really to understand what mode of communication would be optimal for information dissemination within social networks of young Black adults, young Black women. So what we did was we collected network data from young Black women who were age 18 to 24. And we used respondent-driven sampling to understand it was a part of a larger study, but we used respondent-driven sampling to collect the data. So we were able to find out who was connected to whom within our network. And then we also collected egocentric data for each of the young Black women who participated in this study to understand how those direct connections influence their behavior and knowledge. So this study actually just focuses on the more sociocentric network data. So looking at who within the study is connected to whom within the study, and then how their communication to each other influences or creates an opportunity to disseminate information within their network. Next slide. And can you hit enter twice? Thank you. So optimal mode of communication, what does that mean? So our goal really for optimal mode of communication is really figuring out how can we get from point A, one individual in the network, to point B, C, D, and E, everybody else in the network. So say if we were to train a peer leader about sexual health or COVID prevention, how can that information we share with this peer leader spread through the network the most effective or the most optimal way? And so it's like what we do when we're doing Google searches or Google Map, right? We're trying to figure out what's the best way to get from point A to point B. That's optimal mode of transportation or optimal mode of, I'm gonna just say transportation because I can't think of the word right now, but you're really thinking about how do you get from point A to point B in the quickest amount of time using the best method. And so instead of transportation, we're really focused on communication. How do we spread and disseminate this information within a network? Go ahead, next slide. So to do this, I collaborated with computer scientists because one of their main goals is to figure out how to optimize systems. And so I took my real data that I collected from these young Black women, and I said, hey, I have this data from real people, and I need your help in figuring out the best way to disseminate information within this network. And we have these different modes of communication, you know, would you be interested? And they were very excited to be a part of the study and wanted to really figure out, well, how can we disseminate information within these real life networks? Go ahead, next slide. So the measures that we used for the study, I collected network data, and just to give you a brief background of what that looks like. So to collect network data, we used a name generator where I asked everybody to list. So it was 78 young Black women. We asked them to list the last 10 people that they spoke to in the last month. And then we asked them a series of questions about who they spoke to. So who do you talk to on the phone, via text message, or in person? Who do you talk to on Facebook, Instagram, Snapchat, Twitter? We also asked about, you know, who do you talk to about sex? So we asked about all these different questions, and then their names that they selected or entered in the name generator were there where they were able to select each of those individuals who they spoke to. And so this is how we were able to build the sociocentric network based on people they invited to the study and those individuals who they spoke to. We were able to see how this network is linked based on different types of communication. So the variables that we looked at was text messaging, in person, phone, and then since surprisingly in this population, and these are 18 to 24-year-olds, social media, the percentage of talking on social media to network members was actually pretty low. So we end up collapsing all social media. So we didn't look at, you know, the social media individually as Snapchat, Instagram, Facebook, and Twitter. Go ahead to the next slide. So again, our analysis included 5 types of communication. One was in person, the other one was text, phone, social media, and then we did a combination of all 4 modes. So wanted to see what the network looks like if we were able to disseminate information on all 4 modes of communication. We used an algorithm, a computer algorithm called the Grady algorithm, which the computer scientists came up with to optimize the most spread within the network. So figure out the best way to spread the information in a network. And then we had 2 types of analysis, one with any platform. So that's the combination of the 4 modes of communication. And then the other analyses were 1 platform only. Go ahead and hit enter. So this is what our, oh, go back. Yeah, right there. So this is what our network looked like when we looked at all modes of communication. So as you can see in this network, we have 1 large component and then lots of little components, social network components that are separated. So the larger one is, you know, a majority of the young Black women who communicate to each other on different forms of modes of communication. So this can be in person, social media, text message. I'm blanking on the last one. I think on the phone. And so you can see that it's already kind of broken up, but you know, there's still a large component. Like if we selected maybe 5 peer leaders, we can get 1 on each component and be able to spread information to a large reach of young Black women. Go ahead and hit the next one and click it twice. Okay, and then when we look at text message only, we can see that our larger component starts to break down and we lose a bridge. And so it makes it a little challenging to reach more people. Say if we still selected those same 5 peer leaders to spread information, now we have a little challenge because we lost a group of young Black women that we can no longer reach. Go ahead and hit the next one and hit it one more time. Yeah. So when we look at social media communication only, we see that the network really starts to break down. We're losing these bridges, and if we selected those same 5 individuals, the ability to spread information within this network weakens. So we're not able to really reach everybody within this network if we really wanted to disseminate information within this network. Go ahead and hit the next one. So this is what it looks like in numbers. So really, what we found in this study is that all modes of communication is the best way to disseminate information within a network of young Black women, in this network of young Black women. And if we really wanted to develop an intervention and be able to spread that information within this network, we need to consider different forms of, different ways of communicating with these young Black women, different ways that platforms that they can share this information on. So being able to share information in person, on text, via phone, on social media, that would be the best way to reach a larger population. If we wanted to do an intervention and didn't have the resources and said, okay, we needed to select maybe one mode of communication to disseminate this information, what we found was text was the best way to go. It was the second best way to reach most of the women within this network. And so understanding how your participants are communicating and what platforms they're on allows you to really understand the best way to disseminate and implement interventions geared towards this population. Right now, and I know a lot of the trend is to do social media based interventions, but if we were to do that without assessing how they communicate within their networks and understanding how their network is set up, we may not have been able to reach as many people within their network because they're so disconnected and aren't really talking on social media in that same way that they're talking on text message or in person or across all platforms. And I did some qualitative research with this group as well, and what I found, they were like, well, we don't talk on social media, we just share posts and laugh kind of thing, like haha, and they're on social media, they look at things, they use it as a resource, but they're not communicating with their friends and their family in a way that's meaningful. And so that didn't seem like a great place for them to actually do some kind of like HIV or sexual health intervention. So go ahead to the next slide. So my current research is now combining some of that social network analysis and the findings that I had from my previous study and in health technology. So figuring out how to take what they said and then look at these networks and figure out what is the best way to actually disseminate this information within large networks of young Black women. Go ahead. So just the background, the significance. So the study really focuses on, my current study focuses on young Black adults in the Baltimore area, mainly because HIV rates among young Black adults are really high within the young Black population. And another thing I added to the study is after talking to a lot of the young women, and like I said, I collected qualitative data, they said, well, you can't do this without men. So as part of this next study, we're including the perspectives of young Black men as well to understand how we can better disseminate and inform this, group of social networks of young Black adults. Go ahead to the next slide. Actually, I'm gonna skip this slide for now. So I'm gonna jump into the current research. So right now, the aim of my current study is to understand the wants, needs, and priorities of young Black adults when it comes to tech-based HIV intervention. The goal is to understand exactly what they want in an intervention and what modes of communication they feel are important for them to share information. And then adapt a current evidence-based intervention that is used for sexual health and HIV to be on a platform that they feel best suits them, including those features and things that helps them communicate to their friends. So right now I'm doing a sample of 20 young Black adults, 10 male identified, 10 female identified, young Black adults age 18 to 24 in the Baltimore area. And we're doing virtual semi-structured qualitative interviews and a brief social network survey. So to understand what their network looks like and then understand again, qualitatively, what are their priorities and how can we better adapt interventions to meet their needs. Go ahead to the next. So this study really includes community-based participatory research. As a step 2 for our study, what we're doing is creating virtual focus groups, both synchronously and asynchronously, to get feedback on the mechanisms and the features of the study that of the intervention that we're developing. We want to make sure that this intervention is able to be spread within social networks of young Black adults, and we also want to make sure that these are features that allows that spread to happen. So next slide. So these are some of the features that we've talked about so far with some of the young youth. So being able to include like games that they can play that will enhance their knowledge and their skills. And also like face-to-face features where they're able to call and share information with their friends. And this would be more of a, at this time with COVID, an in-person kind of communication, because they're able to call and see a person, and a lot of people aren't really meeting in person in the same ways that they used to. And then some GSI, which is geographical information systems, which allows them to find out what's local to them. So what are some, where's the nearest place to get tested? Where's the nearest places to get resources, and allow that to be custom made for their own place and time. And then another thing that we found in some of our studies in talking about being able to communicate and share information with friends is asking personalized messaging. And so like asking personalized questions or things that really are tailored to their needs and their wants. So natural language processing, which will allow them to ask specific questions and they receive specific responses, and then also be able to share some information with their friends and colleagues, if you want to say. Go ahead to the next slide. So the next step for this project and what we're working on with these young Black adults is figuring out how to combine social network methods with the mHealth technology. So being able to spread our technology within social networks of young Black adults, and then also using some machine learning, because another thing that came up and when we're addressing networks is that networks are dynamic and they're forever changing. And then also the needs of the participants are also changing. So the needs of these youth are changing. And what they wanted to do is have something really personalized for themselves. And so being able to incorporate some features of machine learning, like predictive modeling, and some of the like feedback loops where we can say, based on these characteristics, this is the best intervention for you, but provide us some feedback on what you feel you need, and then we can incorporate that into the intervention, all on the technology. mHealth technology will allow them to customize and create, have interventions that message them in a way that is more tailored to their own needs. And so being able to do that, and then allowing them to also share that content with their friends or whoever they think the information is relevant for. So those are my next steps, and that's how we can use like social network analysis along with some of these other new technologies to really address some of these social determinants of health within like risk, and I'm not going to say risk, within communities that may have disparities around sexual health, and even at this time, really taking this to how can we use the same kind of information to address some of these COVID vaccination hesitancies in the same population, in the same group. Go ahead, next slide. Great, so thank you. So I want to acknowledge first the members of our Community Advisory Board for their time and their support and guidance on this project, the young Black women and men who participate in our research. It wouldn't be able to happen without them. And then also my funding agencies and my School of Social Work at Maryland, and also for my PhD program at USC. So thank you guys all for your support. And then next slide, if you have any questions or comments, please feel free to reach out. I love to talk. I know that was kind of quick, but I know we're running behind, so.
No, that was excellent, Dr. Craddock. Thank you. A lot to think about. Our next presenter is Dr. Tim Oates with the University of Maryland, Baltimore County. Dr. Oates is an Oros Family Professor of Technology in the Computer Science and Electrical Engineering Department at UMBC. He's co-founder and chief data scientist of data science consulting company Synaptic.ai, served as the interim director of the UMBC Master of Professional Studies in Data Science program, and serves as the director of the Artificial Intelligence and Cybersecurity Core in the UMB Institute of Clinical and Translational Research. His presentation is entitled AI and Disparities. Please welcome Dr. Tim Oates.
Okay, thank you for the introduction. I'm going to try and move a little more quickly than I would otherwise, just so hopefully we can end on time. The topic that I wanted to talk about today, as opposed to talking about my own research, is just to pull out some issues that tend to come up when using data to try and address health disparities. And as you can see from the title, one of the concerns is, will data help with health disparities, or might it perpetuate disparities that already exist? So next slide. One thing to point out, I think, especially when you're looking at the popular press, is that data and AI and machine learning typically mean the same thing these days. So when people talk about artificial intelligence approaches to solving problems, really they tend to be thinking about using machine learning and data. So I think it's just important to keep in mind as we go through and have this discussion. So next slide. The outline is just very straightforward. I want to talk about bias. It turns out that bias is a term that often has negative connotations, but machines and machine learning systems actually have biases that we try to build into them to make them perform well. So we'll talk about that. We'll look at a few case studies of biased data-driven systems that perform poorly. Then we'll think about, all right, if machine learning systems can perform poorly with respect to fairness, how do we define that? How do we operationalize that? And then think about what that tells us about how we need to move forward using machines to make decisions in medicine so that those decisions can be fair. So next slide. There are many factors associated with disparities. So age, gender, where you live, how much money you make, how much education you have, what your ethnicity is. Those things tend to be correlated with one another in many scenarios. And machine learning systems and humans pay attention to these things. So in some cases, they're appropriate. You can be more susceptible to certain diseases as you age or by virtue of your ethnicity. But the question is, how are those features used throughout the entire healthcare system? So next slide. One example of that is that there are often disparities at the point of care. So this slide lists a number of those things. If you compare Black patients to white patients, each of these bullets shows a comparative. And unfortunately, the Black patients come out on the wrong end of that comparative in each of these cases. And none of this is surprising. This is something that we're all aware of these days. So for example, Black patients tend to receive less ambulatory and preventive care, for example, flu vaccines and mammograms. So the question is, how does that arise? And I think, there are many, many reasons why those things arise. But on the next slide, we'll talk about one of them. One of them is bias. So just the definition I took from the internet, that in humans, bias is a preference or aversion to a person or a group of people. That bias can be explicit, it can be implicit. When we do hiring at UMBC, we get implicit bias training to make sure that we're at least aware, we're able to kind of think about the implicit biases that we might have so that we can make hiring decisions that are fair and don't pay attention to traits of people that we should not pay attention to when making hiring decisions. Now, typically, as I said, when you think about bias in humans, you tend to think about it as being a negative. But for machines, there is a notion of bias. Bias is a term of art in the science of machine learning, which means a preference or aversion to one model of the data over others, right? So if you think about a machine learning system is trying to learn a model to make predictions and it's basing that on data, there are theoretical results that say learning and generalizing without a bias built in is literally impossible. So the problem is that there are usually lots of models that work well on the training data. I can learn to predict the training data really well, but they don't generalize. And so machine learning practitioners, just as part of the day-to-day business of doing learning, try to build in useful biases. So if we look at the next slide, you'll see an example of that. Yep, so here's a set of data points, very simple kind of problem where I'm trying to fit a curve to the points. I can have a bias for lines. Maybe I just do linear regression, that's all I do, that's all I'm interested in. That's a bad bias, right? On the left-hand side, a line is just not gonna fit that data very well. In the middle, you could say, well, I like lines that aren't too wavy, and that seems like that fits the data well. But on the right-hand side, if I allow my function to turn arbitrarily, there are infinitely many such curves that fit that data, but that make really bad predictions on new data that comes in. So in machine learning systems, you always have to impart some bias, some preference for one model over another if you hope to learn anything that's going to work well. So on the next slide, you like to think, well, maybe machines can do better at avoiding the wrong kinds of biases, the biases that we might associate with human decision making. So typical machine learning setting, you dump a data set in, you clean the data, maybe you have a human sit down and be really clever about constructing some new features. You take some of that data that says, this is how things have happened in the past, you hand it to an algorithm that learns and it builds a model. And then that model can take new instances, right? So here comes a new patient, do they have a particular disease or not? And you're trying to make an accurate prediction. So, that seems all very mechanical. We do have humans touching it at a few different points, but, you'd like to think that machines would be free of human biases. But on the next slide, we'll see that that's not always the case. So I'm just going to present a couple of case studies here that are very well known, but I think very clearly kind of highlight the problems that we have in using data to make decisions. So there's this case study of Amazon doing hiring. Amazon hires a lot of people. They spend a lot of time collecting resumes, reading them over, going through the HR process. So over time, they've got this giant data set of here's resumes and here's what happened with that person. Did they get hired or not? Did we make them an offer? Did they accept our offer? So their idea was, great, this is a machine learning problem. We're really good at this. Let's train a model to rank candidates based on the resume. So the idea is that I can take a new resume in, and then that model will predict, do I think I'm going to hire this person ultimately or not? And then you can just give HR the top candidates, the ones who are likely to be hired, to be made an offer and be hired. It's much easier. You can cut down on costs. Everybody's happier. However, if you look at the next slide, the data set that came in, as you can see, just by looking at global headcounts and employee and technical roles, is overwhelmingly male, right? So, at Apple, Facebook, Google, Microsoft, in tech roles at the time the data were gathered, you've got, upwards of 75, 80% of the people who work there are male. So if I want to maximize accuracy, just in terms of figuring out who's going to be hired, I, as a model, should pay attention to gender, right? So men are usually hired. Let me just serve up a bunch of men. And in fact, that's exactly what happened. So even if they scrub gender from the information available about a candidate, the algorithm starts learning to exploit words. So if I say I was head of the women's chess club, or if I use verbs that tend to be used more commonly by males in the way they write their resumes than females, or if I can look at names and start figuring that out. So the model, even if gender is hidden from it, can start figuring out, well, there are these features that are correlated with gender. It doesn't know that, right? But it knows that when these features occur, those people tend to not get offers and these other people do. So an example of, we've got some historical data. That data represents how people were making decisions, and the machine is simply trying its best to replicate that. So the next slide is another case study. There's a system called COMPASS, which is the Correctional Offender Management Profiling for Alternative Sanctions system. It was used for many years to assess the risk of reoffending. So judges would, use this system. It would produce a prediction as to whether is this person likely to reoffend if they're let out of jail, right? So do I give them parole? Do I give them the option of bail, for example? And race was not a feature available to COMPASS. And it is the case that COMPASS was studied a number of times by different groups, and it wasn't until one very clever group got in there and started looking at the kinds of errors that it makes. So if you look at the table below, COMPASS can label you as high risk or low risk for reoffending. And so the first row of that is you're labeled at higher risk, but didn't reoffend. So that's a false positive. The second row is labeled lower risk, but you did reoffend, right? That's a false negative. And what you can see is that if you look at false positives and false negatives broken down by race, it's much more likely to be lenient on white subjects as opposed to Black subjects, right? So they found there was this racial disparity in there. Again, race was not an overt feature that was made available, but it probably saw other things like your zip code, right? And the location where you live is often correlated with your race in many cases. So another example of a system that was making decisions based on race, and it wasn't discovered for quite a long time. So next slide. The final example that I have is just image classification data sets. So there are some very, very large image classification data sets. So just images of people and common everyday scenes. They are used by the research community all over the world. So there's a tremendous number of papers that are written about these things based on these data sets. The science that's done is driven by trying to do better at various tasks on these data sets. So things like face detection, person detection, finding visual anomalies, summarizing videos. And these things are overwhelmingly white and centered on North America. So again, it's a case of the data that we're feeding into our machine learning systems has this underlying bias associated with it, which means that the outputs of these products also embody that bias. So in the next slide, we can talk about fairness and how do we define fairness. So there is a term used in this community, which is a protected attribute, and that's an attribute, sort of like we saw on one of the very first slides, about people like age, gender, and ethnicity that we think decisions should not be based on. And there are lots of different ways of defining fairness in the community. So maybe if I'm in a protected or unprotected group, I should have equal rates for true positives and false positives. So that was the Compass problem. Compass had differential rates for true positives and false positives based on your race. You could also say, well, if I know your protected status, then individuals who have different protected status, even if they're similar in other ways, should have similar outcomes, right? I know the status of the protected attribute, but if you're otherwise very similar, I should give you the same outcome. And then there's this notion of fairness through unawareness, which sort of says, well, as long as no protected attributes are used to make decisions, then we should be okay. However, we've seen that can also fall apart, right? So for Compass, for example, it didn't explicitly have race, but it was making decisions that looked a whole lot like it did. So next slide. There are a lot of issues around this though. So for example, if I'm really trying to kind of get the true positives and false positives, the ratios of those things to be equal for the two groups, how do I enforce that algorithmically? This notion of fairness, through awareness is, what if it turns out that one of the non-protected attributes is highly predictive, right? Or one of the protected attributes, I should say, is highly predictive and not in sort of a negative way. We're sort of removing information that would be available to the program otherwise. And then for fairness through unawareness, how do I know it's not using a proxy attribute, right? So names are a really good indicator of gender. And if names are left in, but gender is not, I might be using gender to make decisions. And then finally, on the next slide, there are unfortunately theoretical results in the literature that prove that some of these intuitive and valid notions of fairness cannot be achieved simultaneously, right? You, in fact, cannot optimize for two of them at the same time. So that leads me actually to, I think, what might be my last slide. Nope, sorry, I take it back. I got one more slide before this. So it is the case that people are being very clever about this these days. So this slide, I don't know how much sense it'll make to you, but it's a sort of a model of a neural network. You get some input data in. So here's a whole bunch of information about you. What it does is it learns to kind of re-represent that data as a bunch of numbers, right? Just a vector of numbers. I don't know what they mean. The network knows what they mean. And based on that, it is going to make a prediction. But what we'll do is we'll make two predictions. So we're going to train the network to predict, for example, am I going to reoffend? And we want it to be accurate with respect to that based on historical data. But I will also have it try and predict my race, for example. And if it can predict my race, I'm going to say, hey, network, I don't like the fact that you did that. So by having these two things operating at once, what it does is it trains the network to look at the data, to automatically scrub or strip out information that could be used to predict race. And if it can't predict race, then it's making its decisions about whether I'll reoffend, not taking that attribute into account. So there are lots of very clever ways of trying to deal with this. Now I think my last slide. Okay, right. So, what are the lessons that you learn from this? One is that data and algorithms can and do propagate human bias. If I have a data set that's biased because that's the way people have always done it, then the machine learning system is going to go, yep, I'm going to try and mimic what people have always done, and that bias is going to be propagated. The algorithm's not trying to do that, right? But we're asking it, we would like you to do or to behave like the behavior you see in this data set. It's also never really obvious that the problem exists. You have to go and look for it. So in the Compass case, as I said, people actually kind of dug around in that system a few times before one group finally said, yeah, there's a real problem here. Fairness is also kind of hard to define, and some definitions are hard to achieve either individually or collectively. So it's important up front for you in your domain to pick a notion of fairness that works, right? What sense of fairness is important for you and what you're trying to accomplish? And there's a thriving community of researchers that are working on this problem. There are NSF programs, there's money being thrown at this because it really is an important issue. As we use data to turn over more and more decision-making to machines, about very different aspects of our lives, it's vitally important that we understand how are the algorithms biased and how can we discover that, right? And the first step, is just to admit that you got a problem, right? So you have to be cognizant when you're building data-driven systems, this can be a problem, and act to try and root it out. So that's it. Thank you.
That was truly fascinating. I think we all agree with that. Thank you, Dr. Oates. Unfortunately, Dr. Gaskin could not be here today, but we do have just a little bit of time for Q&A with the audience. Maybe we can get one or two questions in. We'll start with this question. Catherine McDonald asks, how are the speakers thinking about the constructs of vaccine deliberation versus vaccine hesitancy or other terminology? I've heard and agree that hesitancy conveys judgment in a way that could be counterproductive to increasing the chance of herd immunity. What do you think about that? Either one of you.
Maybe in the context of social networks, Dr. Craddock?
Yes.
Yeah. I feel like that's a great question.
In fact, you mentioned it, Dr. Craddock, right? You mentioned vaccine hesitancy. So that's probably where that came from.
Yeah. So yeah, that's actually a great question. I haven't considered it, like using a different term that may, and what it may imply. So that's definitely something I think I need to consider. It is something that is being used, that term, on in the media and everything, but I can see it just thinking about creating judgment. I don't think people are intending to create judgment within in the vaccine community. I don't even know how to answer that question, really, to be honest. But and thinking in terms of like social networks. So if we apply this to social network analysis, I think really understanding the reasoning behind which we have a good idea of why people aren't getting vaccinated. And then, as it was mentioned in Esther's presentation, where she talked about the social social contagion within networks. So understanding, people's perceptions of what it means not to get vaccinated or what it means to get vaccinated, and whether or not they're surrounded around people with those same kind of ideas, and how that shapes what they decide to do. I think, as researchers, one thing we need to really focus on is gaining a better understanding of, what does it mean for individuals to get vaccinated and not to, what are the underlining encouragers and around each type, and then what kind of how we can better address individuals who decide not to get vaccinated. And then also, what are ways that we can maybe provide more education or get a better understanding of what some of those blockers are in those networks of individuals? Because I know there's networks where everybody's getting vaccinated no matter what. And then there's networks where there's people who aren't getting vaccinated. And then there's networks where people are on a borderline because some of their family members and friends are vaccinated and some aren't. And then, people don't know what to do. And I think a lot of it is around information and understanding of what it means to get vaccinated and what are some of the side effects. People have their own anecdotal stories, which are shared within networks that make somebody have a decision around what they decide to do and not do. And I think better understanding that, probably qualitatively, and then understanding how people's networks also are connected to who within your network is getting vaccinated and who isn't. And then let's talk about what those relationships are like and how that shapes your own decision making around what you decide to do, is the best way to go on with the next step of understanding vaccinations and vaccination rates within the area and within the United States. So.
Okay. And Dr. Oates, you touched on this a little bit. There's always been a certain amount of concern about AI. Even before there was real machine learning, there's always been this concern of AI. The question here is, AI methods are moving fast. If we're not sure that the data are complete, and if we fear that AI might increase disparities, what can will that slow down the progress that we make with AI? In other words, are we going to throw out the baby with the bathwater? Is that a reason to stop AI?
Right. So I think the answer is no. The amount of work that's being done in AI and machine learning these days is amazing. The conferences are getting huge. As someone said, or I think it was the keynote speaker said, being a data scientist is the most attractive profession right now. So everybody is trying to get into the field. I think what the lesson is that we just need to be careful. So when a machine is making a decision that has an impact on you as a person, then the people who are deploying those algorithms need to keep in mind that these can be issues. And there are ways of trying to measure the extent to which they're making decisions that are biased in a negative sense. And so we don't need to slow down, but we do need to be deliberate about the way we deploy the systems, I think.
All right. Well, I have to be mindful of time. And I know we've had many questions that could not be answered, but we will make an effort to do that. So please reach out to us at Data to Action, and we'll post and tabulate those questions within a couple of weeks. That's data numeral 2 action at rx.umaryland.edu. Thank you, panel. That's going to conclude session 3, and we're going to move ahead to the 4th and final session of our conference today. This session is titled Training the Next Generation. So if you can, please, if you're a panelist in the 4th session, please turn your camera on and be ready to turn your microphone on. Our panel includes Dr. Harold Lehman from the Johns Hopkins School of Medicine, Dr. Arpad Kellerman from the University of Maryland School of Nursing, Dr. Wendy Camelo Castillo from the University of Maryland School of Pharmacy, and Dr. Emily Dow, Assistant Secretary of Academic Affairs with the Maryland Higher Education Commission, often referred to as MHEC. Welcome to all of you. And during this session, if time permits, again, we are going to entertain Q&A immediately following each presentation if possible. So please write your question in the Q&A area as they come to you. We'll start this session with Dr. Harold Lehman. He's professor in the Department of Medicine in the Johns Hopkins School of Medicine. Dr. Lehman is a general pediatrician with his doctoral training in informatics. His research concerns evidence-based medicine, ranging from authoring reports to researching novel methods of delivering research results to opinion leaders and practitioners. His current work focuses on the informatics infrastructure of research, including research informatics support, ontologies for human studies, and for appropriate inference from electronic health records. Dr. Lehman will present N3C and the social determinants of health. Good afternoon, Dr. Lehman.
Thank you very much. And as listening to my bio, I wonder if people might be asking, what is a general pediatrician doing in a department of medicine? And that's a talk for another day. So I am presenting as one member of this group doing SDOH research in N3C, and the work I'm talking about is the result of efforts of a lot of people. Next slide, please. The group is led by, as you can see, Sharice Madlock-Brown from the University of Tennessee, Memphis, by Adam Wilcox at University of Washington, and Jimmy Fong, University of Washington. And the stars show, at least as of the date of the slide, where people are coming from and doing this research. Remember that you don't have to be supplying data to the enclave to be doing research in the enclave. And the one-liner take-home from this talk as regards to the session is that this is an amazing opportunity for junior folks to get involved. We've had people from medical students through professors doing work in this and some of the other what are called domain teams. And it's an amazing opportunity for younger folks basically to rub shoulders, even if virtually, with people from all over the country and all levels of expertise. So I can't say that strongly enough. Next slide, please. So the types of expertise we have just in the social determinants section is from subject matter of both at the domain level as well as methodology. Next slide, please. The general problem is not a surprise to today's group: how to characterize the dynamics between race and other social determinants of health and outcomes in COVID disease. The graphic you see comes from Kindig et al.'s paper from about 10 years ago. Next slide, please. And the activities of our domain team, again, domain teams are groups of researchers working on a common area, So a domain team can have multiple projects, but we share common concerns, methodology, data, and ideas. How can the group work better than the sum of the parts? And as you can see, the activities, besides addressing the questions, are bringing in research data. And the SDOH group, I won't say is unique, but has been the first to really think about how do you bring in data outside the enclave into the enclave, because as you'll see, we need to talk about environmental effects, and we need to bring data about the environment at different levels, and to unite them with the data in the enclave. On the lower left, you see the hackathons using the NC3 enclave. And these hackathons are where we get to play with the data. We get to structure the analysis, to discuss the technical details of what we're doing. Just yesterday, we spent an hour just coming up with the model, the causal model for one of these questions, with ending up bringing in about 40 variables with different patterns into a large model. That's at the high level, and then at the technical level, creating concept sets and doing the statistical analysis. And the lower right-hand side, researcher support, is again where I think junior folks would benefit a lot, not just by rubbing shoulders, as I said before, but also the papers that I mentioned and the conferences and all that other kind of corridor type of conversation that we have. Next slide, please. The specific questions, as you can see, have to do about SDOH, both at the patient level and at the county or zip code level, and dealing, again, focusing primarily on race and ethnicity, but taking other environmental factors and patient factors into account as well. Next slide, please. So the hypotheses are what you might expect. The money, as it were, is in how do we map between the data that we have and the analyses that we want to do. Next. So when we think about the patient level, if you look at the verticals as the data we want, clearly we have cases and outcomes from our biomedical data, and we clearly have, well, we don't clearly have social resource deprivation. We'll say something about that in a minute. We have access to care, but we don't have county health and population health and shelter in place type of. Next slide, please. The patient level, patient reported outcome is really important here. A lot of the SDOH data that you want are not encoded in ICD-9 diagnoses. They're not coded in lab results. They're not coded as visits. Most of the data are elicited through standardized questionnaires, and many of the questionnaires actually have standardized codes, LOIN codes associated with them, but not all the sites are uploading data from these questionnaires. So it's an active area of how do we, what are the data that could be available, that are available, how do we get them? Could we get sites that are not currently uploading them to upload them? So there's quite a fair amount of work on this sort of this patient level data. Next slide, please. But as the commercials used to say, but wait, there's more. So you can see all the other rows are supplied by those external data sources. And you can see from the table that if you look at from the top down, we finally can get each column represented somehow. The only signal we have of environmental existence, as it were, is the zip code. And obviously that's a zip code where the patient said they come from. If you're worried about occupational exposure, that may not be the best choice, but that's what we got. And that is the read upon which our analysis depends. Next slide, please. And so now you can see that relationship between that cartoon from the Kindig article with the data availability as we've articulated. Next slide, please. I'm not sure how much you got to see of the enclave itself so far, But I mentioned concept sets before. These are where concept codes from OMOP are assembled to mean the same thing. But we also have what's called a knowledge store, where more complicated things are made available to researchers. Sometimes there are cohort definition, what does it mean to have COVID? But as you can see in this case, it's entire external data sets are made available. And as I said, it's the effort by people in the SDOH domain team that both articulated which data needs to come in, and then working with leadership, what is the process by which it comes in, so to make sure that no patients get re-identified. Next slide, please. So the special concerns we have in SDOH are not surprising. The fact that the sites that are uploading to N3C are not a random sample. And so how do we come up with a denominator? We already mentioned the problem with SDOH numerators and the PROs. I'll say a little bit about standardization, harmonization, the rest. Next slide, please. Zip code, we have the issue of the cell size. We can't report on any zip code that has fewer than 20 patients, 20 people. And no surprise, there are relatively few zip codes that account for the large proportion of people. There is a rurality project going on in the enclave that is dealing with those sparse zip codes, and they have to face the challenge in how to report the results without revealing the zip codes that they're talking about. I already alluded to the fact that the external data sets have to be reviewed. Next slide, please. Just to review, the data that is brought into the enclave from the left-hand side goes through this, this process that is not legible, but each one of those lozenges reflects an amount of work done to evaluate whether both to do the mapping from how the data comes in to data quality checks, and to and whether we can bring the data into the enclave in the first place. Next slide, please. If from a SDOH perspective, data quality, if you're looking for the harmonized dimensions of completeness, et cetera, obviously missing zip code information makes it hard to bring that site's data in for evaluation, and then plausibility and so forth. Of course, we have the issue with whenever missing data are missing, just like you heard Dr. Oates say that the type of data you have may itself correlate with things that you care about. If there's reason to think that the missing zip code or a site that's missing zip code may in fact be one where SDOH issues are more expressed or more important, we have a very important missing data problem in this project. Next slide. And there's data quality of external data sets. I'm not going to go into the details. Next slide, please. I just want to say a word about this notion of data constructs on the left and analytic variables on the right. It tends to be that you just heard that data science is like the cat's meow and everybody and his brother wants to be a data scientist. And so there's a lot of work on managing data and creating constructs from data, but understanding that the role that variable will play in an analysis is important to understand. And we find that there's an iteration between how you construct your variable and what role it plays in going back. So if you want an employment concept set, you can make it up, but then you see what data are really available, and then you see whether you want it as an outcome or as a covariate, and you go back and you refine the concept set, it goes back and forth. So I find this cartoon helpful to clarify those distinctions. Next slide. And to build concept sets, synonyms of OMOP codes that mean the same thing, this is our current set of issues that once we assemble them, then they have to go into how do we turn them into variables. First, is the data variable? How do we, what are the values? Are there too much missing data? How do we handle the missing data? And then can we put into the model at all? Next slide. So as an example, this is a code set that I assembled for the group. I am not sure yet whether it's still any good. It's got a lot of codes in there. Next slide, please. You can see only about 24 are really used. This is what we call a heat map. So each row is a specific code of a concept, and the vertical is a site. And then either the number or the depth of color tells you how much data of that code are available at the site. And then a judgment has to be made whether are we including too many codes and therefore being too watered down, or are we excluding too many codes and therefore having too many false negatives? And this trade-off has to be evaluated, again, in that iterative notion that I said before. Next slide, please. I've already alluded to the fact that we're just part of the U.S. and how to relate the rest of the U.S. or the geography to what we have in our enclave is not trivial. Next slide, please. And we talked about a lot of bias from a social point of view. I want to point out that there's a lot of bias just methodologically. And in this model is of only 18 epidemiological biases. I'm involved in the EBM on Fire project, which has articulated 188 biases that we have to draw pictures for and make definitions of. And you can see the general population on the left. You can see the data you get out of your computable cohort somewhere in the middle or to the right. And here are all the issues that have to be taken into account as you want to generalize from the data that you have to the outside population. Next slide, please. So in conclusion, we have broad data from many different sources. We have deep in some areas. We have the standard challenges of real world data. I'd like to point out to especially School of Public Health students that EHR data is much harder to analyze than clinical trials data, and clinical trials data is pretty tough to analyze. But when you build a clinical trial, you try to get rid of all those bubbles that I just showed you through design. And here, when we're looking at data sets, we have to deal with them in analysis. So it's pretty challenging. On the other hand, this is an amazing opportunity, not only to rub your shoulders with people doing this amazing work, but I think this is the largest pooled data outside, I suppose, of companies that pool those sorts of data. But so this gives you an opportunity to look at site effects and geographic effects in a way that you can't do in other ways. And hopefully we'll get some really great results. And I think you can get a sense that we actually are creating methodology as we go along. Next slide. So I want to make sure to acknowledge the people whose work I borrowed to put this presentation together, as well as the people who are supporting the work, and I appreciate all their efforts. Thank you.
All right, Dr. Lehman, you moved very briskly through that content. That was pretty impressive. I think we have time for maybe one quick question. It has to do with capturing all those determinants of social health data. What do you think we could do? What's the optimal way to capture that kind of data in electronic health records, particularly in N3C? And what would that do to medical encounters? What would that, is that even feasible?
In 30 seconds. Okay.
Well,
no. So that's a very wise question, because certainly the EHR vendors are putting the capability to elicit social determinants of health data into the record, both through the PROs. Those are all, the questionnaires are being implemented one way or the other in EHRs, and the data are coming through in computable ways that can be uploaded to N3C. And I think that notion of what gets asked during the encounter is an excellent one. Obviously, we should have patients giving data from outside the encounter, not relying on a doctor talking to a patient. recognizing that the people who have the hardest time giving you that data because they don't have all the machinery to give you the data are just the ones whose data we need. So that would need to be worked out. But well, I think so. The world may not be great as the data may not be as greatly available as we want it at the current time, and it only looks brighter for it to becoming more available.
Wonderful. Thank you, Dr. Lehman. Our next panelist is Dr. Arpad Keleman. He is professor of informatics at the Department of Organizational Systems and Adult Health in the University of Maryland School of Nursing. Dr. Keleman has expertise in biomedical informatics, database development, software and game development, human-computer interaction, artificial intelligence, and data mining. He currently leads development of a motivational mHealth game and cloud database for patient behavior, tracking, and improving health outcomes. It won't surprise you that his presentation is entitled Learning Models, Motivational Mobile Health Games. Welcome, Dr. Keleman.
Thank you for the introduction. The project is actually called Walking Warrior. Walking Warrior is a mobile health game that I'm currently developing with a team. And this was specifically designed and developed for hematopoietic stem cell transplant patients. Next slide, please. It is known from research that fatigue is a common side effect of cancer patients receiving the bone marrow transplant or hematopoietic stem cell transplant. The exercise is also known from research to reduce fatigue, but the adherence to the recommended level of physical activity is low in this patient population. So what we came up with one of my students, who is a Master's of Science student in nursing informatics, is to try to motivate them with a game. Next slide, please. So when we started this project in 2017, she went to the Johns Hopkins bone marrow transplant unit where she also worked, and she found out that already more than 80% of the patients own the smartphone. And we know from Pew that this is actually increasing in the general population. Also, the majority of the patients receiving the transplant are less than 60 years old, which makes them somewhat more of a candidate for a game because of the known digital divide between the younger and older populations. The patients can be either inpatients or outpatients. And although we primarily design and develop the software for this specific population, which is a very narrow, small population, to motivate them to walk, we also try to design and develop this game to make it generic and suitable enough for a wider population where walking is part of the medically described therapy. Next slide, please. So since the game is designed and developed to partly to entertain and also to motivate them to walk, we went to try to design that at the appropriate level of not being too boring, not being too hard, and also to give replayability, as any game should have that. And the randomness comes in, so no two puzzles are exactly the same. And we also wanted to track these patients. So we designed a backend relational database, which is stored on a web server, where we automatically collect the patient/player performance data, specifically how many steps they have taken and what scores they received in the various levels of the game and when they played the last time. The idea we came up with is that they will alternate walking and playing. So when they complete a level, then the game sends them to walk the therapeutically prescribed number of steps, and then that earns a token, which they can use later to unlock the next level, to play more. This is kind of similar to what we used to have in the 80s. If you remember, you had to throw in a quarter to allow you to play when personal computers were still very rare in the wider population. They would earn that token with walking. That's our hypothesis. Next slide, please. So the entire project included the ideation, come up with the concept, what we want to do, the design of the various software pieces, and how they interface with each other, and what the game rules are, and what the patients have to do and so on. The development, which primarily includes, of course, computer programming. And we have also done an expert heuristic usability evaluation, which is done by a small team who is not part of the study team, but they are domain experts, either in computer science, game development, or in bone marrow transplant nursing. We have done a lot of bug fixing, and also we keep developing the new prototypes of the game and eventually get to a version when we feel that it's robust enough and stable enough that we can give it to the actual patients to play. The participants will be required to carry their own phones for the walking, because the step counter part of the project is on a phone, the mobile phone that we have, and they have to carry it with them. And the team, the development team, included a computer science professor of nursing informatics, myself, a nursing informatics Master of Science student, oncology nurse educators, computer programmers, statisticians, consultants, and many testers. Next slide, please. We started by asking 30 patients at the bone marrow transplant unit of what kind of mobile games they already play and what they enjoy. And 21 out of 30 answered that they liked puzzle games most. Specifically, 11 out of 30 said that they liked Candy Crush. So that gave us the go-ahead to try to design a game which is motivated by Candy Crush. But the only thing what we really copied from there is that the basic idea is to try to create 3 of the same kind in a row or a column. But everything else is different. We have different rules, we have different graphics, different winning conditions, a different sound effect, and so on. And you know it from research that Candy Crush is not limited to any specific demographics. The game is played by users of all age groups, belonging to all races and ethnicities, all religions, on all continents. So that gives us also a strong footing that this game is not just for a niche population. This can be really appreciated by a wider population if done correctly. Next slide, please. So the short-term study goal is specifically for this group of patients who already received therapy at the bone marrow transplant unit at Hopkins. They are older than 18 years, and they received already the instructions about walking, and also they know that it's part of their recovery plan. After the medical procedure was already done on them, and they will need to have an Android device to play the game and to do the step counting. There's a specific reason why it's Android. I will get there later. The game also has a download link to the step counter, which is a separate app. And the game itself looks like only a 9x6 grid with 6 columns and 9 rows, and they need to simply move the tiles sideways or vertically to create a match of 3. The graphics was decided to be similar and relevant to their therapy, specifically including various biological cells and various pills which they are already taking as part of their therapy. We also added various other difficulties in graphics, such as bricks and blocks, which are only to make the logical challenge harder for them. We made a decision not to include cancer cells specifically, not to remind them of their condition. And each level, we have a total of 23 levels. Each level has a different winning condition, so they are not the same. Next slide, please. The backend database, which is on the server, is designed to collect the data from the players, which can be reviewed by the clinician to see what is the progress, both in gameplay and in walking, also to motivate them and to reinforce the behavior which they already know from the education that they are supposed to walk. And it's also as a proof of actually having done the walk, and it's automatically collecting the data anyway, so they don't have to send the data manually. And when they finish a level, They are being sent to walk 500 steps, which is clinically prescribed. That earns a token. A token is being sent to the database, is stored there. From the database, it's further sent to the Walking Warrior game, which unlocks the next level, and they can continue to do this. And we collect no personally identifiable information, only the usernames and the basic performance data in the database. Next slide, please. These are some of the technical details. The main game development, which we have done from scratch, we copied no code from anyone, was done in JavaScript, and it's available at that website at URL. We stored the source code in a standard GitHub repository. We optimized and tested on Android smartphones, although it is supposed to work on modern devices and internet browsers, because JavaScript is specifically a programming language which helps client-side computer programming for browsers. And there is also a bug reporting button in the main menu. From there, they are being sent to a standard Google form, and the development team can look at that and fix the bugs as it's being reported by any tester. The step counter itself had many versions, and currently we use an open source Java, which we have found online, and we further modified it. And that actually locked in our project to Android. First, we wanted to make it for any mobile device, but we didn't find a good open source step counter for iPhones, and the built-in step counter turned out to be not that good. So for now, we are focusing on Android, and we can add other devices later. The handling of the user logins on the server side was programmed in PHP. The database is a relational MySQL database, and data transfers go through Ajax, which is helping with client-server communication, such as not forcing the user to refresh the browser to get the updates on the display of the data. Next slide, please. This is the basic flowchart of the game. This is what the actions and the events are. So we start on the top, where the player starts an individual level, which has the winning objective and also the number of moves available. And then from there, it goes to the blue diamond, where the game options for the players are, and this is at the abstract level. Of course, there are many ways you can switch tiles. You have more than one options, and basically you can try to make a match of 3 or a match of 4, a T shape, an L shape, or even using some of the special buttons, such as an X or a arrow button, which can do additional various manipulations to the game state, which are not available at all levels. But once they keep doing this, eventually they reach an end state when they either won because they met the objective, or they lost because they ran out of ideas, or because they ran out of moves. And in this case, if they won, then they have to walk the 500 steps, and it's going to send the token, eventually get to the next level. If they lost, they need to replay the level. Next slide, please. These are the instructions which explain to the players what the rules are, what the tiles look like, and what they mean, and how the scoring happens. And basically, we just try to make it as brief as possible and still get the message through. And this is available to the main menu. Next slide, please. And this is how the game itself looks like. It is in a vertical position, so it's not going to change if you rotate the phone. There's a bottom and the top. And the individual move is just to use your finger and simply slide any of these tiles, either up, down, or left, right, trying to make a 3. And if you do that, then that is going to disappear, and other additional tiles will fall in from the top, some random tiles. We don't know what they are going to be. In addition, we also see that there is a bonus cell on the bottom right, which is in the right circle, which gives additional points if they generate it and use. And it can be done if they match, instead of 3, they match 4. And they also have the blocks and the brick, which are just for additional challenge to make the game difficult. Those are not always available, only on the more difficult levels. And we also see the number of moves left, the number of tokens, and also the current score, and also the objective on the bottom, what they are trying to do. And on the right side, we also see the arrow and the X. The X is going to simply blow up a cell, and the arrow is going to force a move, even if it would be illegal otherwise. But these are very costly operations. They will cost multiple moves, and there's a limit how many times you can do that. Next slide, please. This is how the database looks like. So an individual row is a record. It shows the username and the current number of tokens, what was already earned, the number of steps recorded on the database side, the overall score, what they get in the game, the highest level they reached. We have a total of 23 levels, the account creation date and time, and also the last time the record was updated. Next slide, please. So after this, of course, it's wise to do internal usability evaluation, and that's what we have done. We created a 40-item expert heuristic questionnaire, and that was used to evaluate current prototype, not a current, but it was actually like a year ago, a version of a prototype of the game what we had at that time. And we recruited 4 game development computer scientist experts and 1 bone marrow transplant nurse. And this is in addition to the other computer scientists and bone marrow transplant nurses who we had on the study team. Of course, we didn't hire them because that would be a bias. They played the game for 2 hours. They heuristic tried to test as many random features as they could, and they used a standard Likert care survey from 1 to 5, where 5 would mean strongly agree with the statement, and 1 meaning strongly disagree. Next slide, please. After this was done, there were a number of areas which were identified of being weak or potentially need improvement. And one of those was the step counter. It turned out that the universal step counter, which was built in the phone, it came with it, it was not that good. It was not easy to access it. This is not counting the steps well. So we decided to find a better step counter than the one what we had. And for that, we recruited 5 additional usability evaluators. These were all nursing informatics Master of Science students. And they went out and were searching for open source step counters. And the open source is good because that means we can see how it was coded and we can legally use it and modify it further. And that's what we did. They found 4, but all for Androids. At that point, we lost the iPhones because we couldn't find any open source step counter for iPhones. So we compared these 4 open source step counters and also compared it to the existing one, specifically on the accuracy, robustness, cheat proofing, ease of use, and battery drain. And we chose the winner. It's also important to mention that in general, step counters are not perfect. They will always make mistakes, heavily dependent on the hardware. To the different phones, we count the same steps differently based on their built-in gyroscopes and their accelerometers, and even they might use GPS technology and so forth. And they also have algorithm built in which classifies the moves into step and non-step events. Next slide, please. The overall suggestions from these evaluators was that we need to improve the improvement and the ease of movement of the tiles by the finger and the graphical representation, as well as the accuracy of the step counter. But they also acknowledge that the game was casually fun, suitable for the target audience, and the overall concept had a high potential. And we replaced the old step counter with the new one, which we still continue to improve on further. And they also found out that the best way to use the step counter is either to strap it to a body part or to put it in the pocket, as opposed to hold it in the hand or put it in the backpack. That is not that good. Those will make more mistakes in counting the steps. Next slide, please. So this is how the result of the survey looked like. So a total of 40 items grouped into 5 generic areas. So clarity and ease and appropriateness listed on this slide. Everything is above 3, meaning positive, except a few lines. So we can see that the reading was a problem. So apparently there was too much text, and maybe the English language was not well phrased. So we need to improve a little bit on that. Also, there were problems with the step counter. So it was difficult to access it. And also it was not counted counted the steps accurately. So this gave us, of course, the motivation to work on these areas specifically. Here we can see on the right side the mean, the medians, the standard deviation, the difference between the two groups, and the percent agree and percent disagree with the individual statements from the expert usability group. Next slide, please. Here, additional areas are the game quality, the working motivation, and the mental effort. Again, everything is slightly or moderately positive on the upside, except there were some concerns about the music. Music was not perceived as being pleasant, so we added the mute button. That's one thing. And also, of course, we can change it further. And the working motivation, that's also a questionable area. Although the question was not whether you think that the patients will be motivated to work, but whether you are motivated to work. And unfortunately, it came back slightly negative. These testers, they did not feel that they were motivated, but for the patients, we still don't know. And we have to work on it because that's one of the key hypotheses we are trying to evaluate with this project. Next slide, please. So in conclusion, and for near-term future work, of course, we would like to finish this current stage of bug fixing and getting the software in a robust and stable stage when we feel comfortable to give it to the already IRB approved study and recruit 20 patients from the Johns Hopkins bone marrow transplant unit. And they will be recruited and consented. They will need to use their own Androids to play and work, and then they will do their own usability evaluation, which should be a subset of our earlier questionnaire. And they can optionally also provide text feedback of how they think we should further modify the game, which of course we will do at that time. And once we have that, once we integrated the patient's opinion on an existing version of the game, then we make the change and try to give it to a larger group of patients and do a more rigorous evaluation that will also include the feasibility evaluation of the intervention, the acceptability by the target population, and the possible potential impact on their behavior. And of course, we also want to make it available as a therapeutic tool for a wider population and to further modify, customize it to make it available to them, and not necessarily impose the clinician set goal, but even the players can set it for themselves. Thank you. Next slide, please. I would like to acknowledge the Center of Excellence in Biology and Behavior across the lifespan for funding the study. And the next slide shows some of our early publications. We already have a journal publication and 4 conference presentations on this project.
All right, thank you, Dr. Kelman. That was a very thorough explanation, fascinating. Joining us now is Dr. Wendy Camelo Castillo. Dr. Camelo Castillo is an assistant professor in the University of Maryland School of Pharmacy. Overall, the goal of her research is to inform and improve clinical and policy decision-making by providing evidence of benefits or harm from the real-world use of pharmaceuticals in pediatric, young adult, and vulnerable populations. Through her work, she integrates the patient perspective into epidemiology and health services research. Here with her presentation, mHealth in the Curriculum, is Dr. Wendy Camelo Castillo.
Thank you very much for this kind introduction. And first of all, I would like to thank the organizers for the opportunity to present today. This is very exciting, as this is the first time that we're presenting any results from our study. So next slide, please. Now, before I begin, this is the acknowledgement that this project is supported by the Food and Drug Administration, and that the contents are those of the authors and do not represent the official views of, nor are an endorsement of, the US government. Next slide, please. I will begin today's presentation by providing an overview of the work that led to the development of the MindPower app, or the MindPower study as we call it. I will describe also how stakeholders were engaged in this work and how throughout the study design and development of the app, we've been engaging trainees at multiple levels, whether it's PharmD program or even some high school STEM students who have been involved in our project. At the end, I will discuss some of the opportunities that we have in terms not only of understanding newer data sources, but also how can they be better integrated, not only to generate new knowledge, but also to address some training gaps. Next slide, please. So before I begin, I would like to provide some context on the MindPower study. Next slide. Despite evidence from clinical trials, really little is known about which are the predictors of early response after initiation of antidepressants in adolescents. We know that only 30% of adolescents will respond within 12 weeks of initiation of treatment and will likely go into remission. But there's a 40% for which response is not achieved. And this has very important public health consequences because adolescents who do not go into the remission are more likely to have mental health burden throughout their lifetime. So we really want to be able to provide the best care possible, the earliest possible in their, disease journey. Also, one of the challenges is that clinically, some of the responses to treatment are typically assessed through like improvements on sleep, improvements in mood and behavior. But the way the symptoms are assessed are through clinical questionnaires that are based on 7-day report. And these reports are often self-report. So as you can imagine, if I were to ask you today, how well did you sleep in the last week? Probably you will base it off of the last 2 nights. So if you didn't have a really good night last night, then probably your assessment of the week is going to be slightly biased. And this can be very challenging when trying to determine whether a teen has been responding or not to treatment, because based on that report, some decisions will be made in regards to whether treatment needs to be augmented, whether there needs to be a change in treatment, or whether the adolescent will continue on the same treatment regimen. So we also know that sleep, activity, and mood are cyclical and are quite dynamic. So again, I would invite you to think about your own mood, for instance, today. You would likely, maybe if you saw the sunny morning today, you woke up thinking, oh, this is going to be a great day. I'm very energetic. And then as the day goes by, maybe you had a meeting that you didn't like that much, or maybe you had something that, soured your mood. Then your mood is also going to change over time. So depending on when I ask you how you felt today, you might think that, today is a great day, or you may think that your day is not going as well. And this has also important implications because, again, when basing our assessment on improvement on mood, especially mood and other behaviors, it is very challenging to rely solely on self-report. I also have to add here that typically parents or the caregivers will be present at the visit, and therefore they can also provide their own perspective on how the child's behavior and how the child's mood has changed or improved with treatment. So as you can see, the decision becomes very complicated because we don't have objective measures on symptoms that we know may vary quite a bit over time and that may be very dynamic. So there is evidence to suggest that within individual variability of symptoms and sleep patterns could indicate early response or even lack of response to antidepressants. So in light of that, then the question becomes, how do we measure such variability? And if this could be measured, can it be used as a predictor of antidepressant response? Next slide, please. This is the motivation behind the MindPower study. So the questions that are guiding our work are whether mobile health apps and wearables, in this case an activity tracker, can be used to improve upon or improve the measures that we currently obtain from clinical instruments that are used to measure mood, sleep, fatigue, and activity in adolescents that are being treated with antidepressants. And the second big research question is, can we actually characterize those patterns? And in the future, can we use those patterns to predict early or lack of response to treatment? Next slide, please. So our goal with this pilot work is to develop a mobile health app that's paired with an activity tracker that in this case is going to be Fitbit, will allow us to capture real-time data on mood, fatigue, activity, and sleep. And also through this data, potentially identify patterns in the symptoms after adolescents have initiated antidepressants. Next slide, please. So for this purpose, so besides designing the study, of course, designing the study, we decided to frame it around the use of an activity tracker paired with an app that will allow us to assess the changes in these symptoms throughout a period of 4 weeks. So what happens when a teen is enrolled in our study? So the types of teens that will participate in our study are those who are diagnosed with mood disorders, who have recently initiated antidepressant treatment, and who, even if they have other mental health conditions, they have been stably treated for those conditions in the last 3 months. So as you can imagine, these are teens that could potentially would benefit from understanding whether they respond early to treatment, because this will have very important consequences in terms of the treatment as they move forward into remission. So in our study, when a participant enters, the first thing is that they will be assessed through clinical tools, some of them that are typically used in clinical settings or that are used in clinical trials. For example, the CDR-SR and the CESDC, both tools assess all these symptoms all together. But we also at baseline are able to capture information, demographic information and clinical characteristics that will help us inform or characterize better the cohort of participants that will enter the study. Once they enter our study, the teens are granted access to the MindPower app, and they are provided a Fitbit that they are required to use 24/7, so that we can capture passively activity, heart rate, and sleep patterns throughout the 4-week period. And through the app, they will be sent questionnaires 3 times a week, where these questionnaires are based on patient-reported outcomes measures that were developed by Promise and that have been validated for this age group on mood, fatigue, and sleep impairment. And an additional component of this app is that we have a parallel sort of app that caregivers use. And pretty much caregivers are being provided with questionnaires that also address mood, fatigue, sleep impairment, are also promise-based questionnaires developed for caregivers as a proxy report. And therefore, we are able to obtain pretty much the full picture of the mood and behavioral changes that the teen may have once they initiate antidepressants. Teens will be followed over a period of 4 weeks, after which they will then follow up in our study. They will come to an end of study visit where we will reassess them using the clinical tools that we mentioned in the beginning, and that will end their participation in the study. Typically, trials do a 12-week follow-up at a minimum after initiation of treatment, especially when testing efficacy of antidepressants. But for our purposes, and since this is a pilot study, we decided to start first with a 4-week period as a way to understand any potential challenges with usability, because it is important to acknowledge that this population may be slightly sensitive and could potentially face some challenges. Next slide, please. So one of the important things about this app is that from the beginning, this work was guided by our stakeholder group. And next slide, please. And this is very important because our stakeholders were engaged in all stages of our study design and implementation. And this figure illustrates who were the different stakeholder groups that provided feedback, not only with the study design, but that are currently also supporting us through the pilot phase. So we have, of course, the team from the University of Maryland. We have an advisory board that includes youth representatives and caregiver representatives. And these representatives are individuals who have experience with mental health conditions. We also have a team from the FDA who has been with us since the inception of the study. And of course, our technical team represented by HIDLAB. Next slide, please. So the slide basically illustrates all the different stages and the different contributions that our stakeholders have had throughout the project. We spent pretty much a year or more in just development and agreeing on which were the different measures and what would be the best measures that reduce participant burden, considering some of the sensitivities in this population. And currently, all our advisors are supporting us with recruitment activities to be able to meet our numbers for the feasibility pilot. Next slide, please. So one aspect of this, of course, is the research aspect, and is, the design, the measures, how we develop the app, and what we're hoping to obtain out of this work. But an additional aspect of it is the impact that this type of research has on current trainees, at least in our doctoral program and in their School of Pharmacy. Next slide, please. So as of now, we've had the opportunity to involve up to 8 trainees. And I have to say this number is a little bit loose because probably the impact is a bit more large than just 8. As you can see, we've engaged trainees at different levels, who are at different levels and at different programs, not only within the School of Pharmacy, but also within the School of Medicine. So when we think about trainees in the doctoral program, they're the ones that have been involved the most with aspects that are related to study design and to the development of the app itself, and of course the feasibility pilot. But we've also engaged PharmD and clinical trainees from the School of Medicine in the testing of the app, in the development of the prototype, and of course currently in the feasibility pilot. Something that I wanted to point out is that we even had a high school consultant, which has provided great feedback in finalizing and refining some of the aspects of the app, given that teens in the end are the ones that we would want to like the app the most. Next slide, please. So what I see here is that there's like multiple opportunities, and all these opportunities include anything from critically assessing the evidence on the use of mobile health apps in mental health, I guess, context. From developing the measures and identifying which would be the best measures that we could utilize that were validated and that would give us sort of the most information when collected routinely through the app. Of course, the whole experience of working with multiple stakeholders, working with the technical team, also exposes trainees to interdisciplinary and multidisciplinary teams, which is sometimes challenging. It's easier when we think about interdisciplinary, we typically think about those teams who are in the health sciences or in the clinical sciences. But when you start having conversations with those in IT or in areas that you're less familiar with, that type of exposure is quite valuable, also to improve different communication skills. Next slide, please. So what are some of the upcoming opportunities? Next slide, please. So I see that there are opportunities at 3 levels. Definitely from a data perspective, is irrefutable that there's a lot of interest in patient-generated data and how this can inform not only epidemiology, but how can this be applied into clinical practice. Definitely there's some frameworks, but there needs to be more work in terms of newer frameworks and the usability of different measures such as patient-reported outcomes in the context of mobile health technologies. On the other end, when we think about the knowledge that is being generated, specifically for this project, this is quite novel. Even when you look at clinical trial data we really don't have a good understanding of how daily symptom variability can potentially affect clinical decision making. And therefore, this is definitely an area that is not exclusive of mental health. We're seeing some of this work also start in the cancer setting. And so it is, I think the more researchers collaborate with technology developers, we will be able to develop more solid applications that are founded in research principles, but that are also founded in good, theoretical backgrounds. Sometimes I feel that the disconnect is that on the technical side, we're very sound, on the research side, we're very sound, but we need to start thinking jointly about how to best develop methodologies that allow to generate evidence using these technologies. And of course, the last goal is how do we incorporate this into training? And I see where this, still a gap that will probably evolve over the next 5 years. We see that technology is rapidly evolving. And in some ways, it feels like academia is sort of catching up. We see a lot of, training opportunities that are coming with data science, that are coming with, health technologies. But there is a gap in terms of identifying what are the best methodologies that allow us to assess these technologies. And I think that's where we have an opportunity to fill that gap with our own trainees. Next slide, please. So I guess to conclude, I would say that definitely this space provides a lot of opportunities for interdisciplinary collaborations and interprofessional education. And I think this is a great opportunity, not only for our campus, but potentially for collaborations, across the University of Maryland system campuses or campuses within the ICTR. And I think the biggest challenge is the playing catch-up part. How can we ensure that from the expertise that we can provide in terms of sound methodological study design, how can we better inform all the use of the different technologies that are coming into market? What we see is that there's tons and tons of technologies. Not all of them have a solid evidence base. And of course, there's another larger picture question, which is with all these new technologies that are coming into the market, from an academic perspective, how do we also think about developing more inclusive technologies that don't leave important segments of the population behind? The next, I think an important issue or important point to discuss as well is the role of virtual designs. We are slowly transitioning into virtual spaces. COVID pushed us to move all our studies into the virtual space. But we also need to design protocols and study designs that are appropriate. And at least from my own experience in modifying my own work to fit now a virtual reality, this has raised a lot of different questions. So certainly this is something that we are all going to face moving forward. The last question is just something for you to think about. Are our trainees ready? And what can we do to make them ready for this new reality? With that, I would like to thank everybody for your attention, and please feel free to email any questions that you may have. And of course, I'm open to any questions that the audience may have at this point.
All right, we're going to wait and see how much time we have left at the end here for questions, since we're getting to the end of our webinar. But thank you very much, Dr. Camila Castillo. Our final presentation for the day, will be made by Dr. Emily Dow. Dr. Dow is the Assistant Secretary of Academic Affairs for the Maryland Higher Education Commission. Dr. Dow is trained as a developmental psychologist with a focus on educational policy. Before joining MHEC, Dr. Dow worked at the United Nations and with the American Psychological Association to promote psychological awareness in the global context. Her presentation today is entitled Trends in Data Science Education Programs. Dr. Dow?
Great, thank you. Good afternoon. I am the last presentation. For those of you who are hanging on, thank you. I appreciate it, and really am honored to be here. I've listened into a number of the earlier presentations, and man, I'm here with some very smart people. So thank you. I have been asked to talk about trends in data science education programs. So I'm going to kind of deviate from what you've been hearing. As my introduction says, I am the Assistant Secretary for Academic Affairs at the Maryland Higher Education Commission. So you may not know who we are. So next slide. We are the state agency that oversees and regulates post-secondary education in Maryland. So we work with all of our colleges, universities, public, private, 2-year, 4-year, undergraduate, graduate training, and our private career schools, those small, often mom and pop cosmetology schools, truck driving schools. So we run the gamut. We work with maybe about 200 or so institutions throughout the state. Including out-of-state institutions that operate here in Maryland and institutions that offer distance ed. So we do quite a bit. The other thing that our agency does is we issue out a number of scholarships. I never want to leave that out. We issue out about over $100 million in state scholarships. So if you know someone, if you are looking for some scholarship money, head over to our website. We have lots of scholarships. Okay. To the meat of my presentation, next slide, please. You may be aware that as scientists, there are classification codes for academic programs that are, and these codes are determined by the federal government, by IPEDS. They just every 10 years, they update those classification codes. So the 2020 classification codes came out in 2019. And you will be happy to know that a new code was created just for data science programs. So it is the SIP code of 30.7001. And they use this descriptor to describe data science programs. So bear with me while we read through it. An academic program that focuses on the analysis of large-scale data sources from the interdisciplinary perspectives of applied statistics, computer science, data storage, data representation, data modeling, mathematics, and statistics. It includes instruction in computer algorithms, computer programming, data management, data mining, information policy, information retrieval, mathematics modeling, quantitative analysis, statistics, trend spotting, and visual analytics. Many of these skills, the presentations you heard today, leverage these skills regularly. So this is certainly a burgeoning field. The fact that the Department of Ed recognizes it and has developed a unique code to identify these kinds of programs is exciting. I will also share that the federal government also created some additional codes specific to data analytics. And so you'll see that in the bottom right-hand corner. For data science, they just have this code, this kind of blanket umbrella. But for data analytics, they've drilled down a little bit to talk about specializations, things like business analytics versus data visualization, financial analytics, and then they have kind of an other catch-all category. So when you're thinking about academic programs and training the next generation, which may very well be the generation that's graduating in the upcoming months, thinking about how we categorize those education programs and what that means for kind of the market demand of individuals who are specialized in this field. Next slide, please. From a news article from the Chronicle, I thought this was a good comparison about the interdisciplinary element of data science and data analysis. Again, I know you all know this, but it's worth just highlighting. And so the article references Dr. Kolacek, and he implies that gamma represents data science. And so in a typical data science program, the long leg represents deep training in statistics and computer science skills, such as probability, inference, and developing algorithms. The short leg represents coursework in a domain area that supplies data and questions. So I think, again, the presentations today have highlighted that there are the skills of being a data scientist and having data analytical skills, but then there's content around that, and having recognition and awareness and an understanding of either a theoretical or very practical applied understanding of that content is really important to actualize what data science is and what data analytics can do to help inform our work as researchers. Next slide, please. We do have a number of data science programs in Maryland. They vary quite a bit. So we have Frederick Community College. They offer an area of concentration in data science. The area of concentration is within a STEM degree. So again, thinking through that kind of, you're having some content analysis and then some data science skills. Montgomery College has a lower division certificate. Salisbury University, a bachelor's, and you can see the rest. We do have a handful of graduate programs, particularly at Capital Technology University. Their data science is specific to business fields. And then Hopkins is focused in public policy, data science and policy. So again, this kind of interdisciplinary, it's not necessarily a standalone, but it does have some content and some meat to it to help answer questions and think through those questions. Next slide, please. When we talk about market demand, and again, I know some of the presentations have highlighted a bit of this, unfortunately, despite the fact that the federal government, Department of Ed, has kind of caught on to data science and data analytics, our US Department of Labor has not yet quite caught up. And so when we look at categorizations of different employment, really statistician is the one good fit. And so when we look at Maryland projections, there's certainly an increase and there's going to be a demand. They account for about a 27% increase over the next 10 years for statisticians specifically. But I think that this is a floor number. I think we certainly can see from market demand in general, data scientists need to have that content expertise, and that they are not just standalone statisticians crunching numbers, but live within lobbying groups, research institutes, and other employment opportunities. Next slide. There was a recent 2017, recent for higher ed purposes, a recent article, a research article that talks about the need for data scientists and data analytic expertise in the market field. So the market analysis calls for annual job openings to rise steadily to 2.72 million postings for data science and analytic roles in 2020. And so here we are in 2020. If you do a quick search on Indeed, you get those quick counts that data science, data analytics, research skills, ability to collect data, understand data, those are criteria that you see in a lot of job postings. In this article, in this report, they talk about things that higher ed can be doing around this, things like stepping up professional ties, thinking about the words we use when we develop academic programs, consistent outcomes, curricular outcomes, talking about things like creating hubs and silos, again, that interdisciplinary nature of what data science and data analytics can be. But what I really would like to focus on is they make recommendations about designing for inclusion and championing data literacy for all. So next slide, please. So you may be aware in Maryland, we have general education requirements. We recently, again, 2015, we recently changed the gen ed requirements at the undergrad level to be more than just college algebra. So before 2015, the gen ed requirement for mathematics said literally just one course in mathematics at or above the level of college algebra. And in 2015, we came around and we said, you know what, we need to have a much more inclusive definition of that mathematics training. And so what you see on the screen here is the current requirements for mathematics in general education at the undergrad level. So one course in mathematics having performance expectations, demonstrating a level of mathematics maturity beyond the Maryland College and Career Readiness standards, including problem-solving skills, and mathematical concepts and techniques that can be applied in the student's program of study. So what this did is it expanded that general education mathematics requirement to go above and beyond that traditional algebra calculus route and think about things like quantitative reasoning. And so this is kind of one step forward about how we can talk about inclusivity of data science and data analytics within the curriculum. Next slide, please. I also want to highlight a project that recently ended on remedial mathematics. Again, this is at your undergrad level, but these are opportunities to engage undergrad students in thinking through what it means to collect data, how to ask questions, how to design a good research study, and then what do you do with that data and how do you analyze it? Students who are deemed needing remediation or deemed not necessarily college ready in mathematics traditionally only have that algebra calculus route. And so the University System of Maryland received a grant called the Maryland Mathematics Reform Initiative, where a number of institutions gathered together, both our community colleges and our 4 years, to identify alternative pathways around remedial education. So in the very simplest form, I'm an English major, I'm tested to need remediation in math. College algebra is really kind of making it hard for me to graduate. I'm not going to use those mathematics skills. Let me take a quantitative reasoning. Let me take a statistics course so that I can understand numbers a little bit differently, but I'm not moving into that calculus route that I'm not necessarily going to use in either my profession or everyday life. So what this group did is they came up with agreed upon course objectives, common curricular materials, common advising materials. So it's created this kind of unique pathway for your non-STEM undergrads to access a mathematics curriculum that still challenges them around quantitative reasoning, data analytics, thinking through what it means to be a 0 versus a 1. And providing that kind of introduction to math that they may not have had exposure to in previous educational opportunities. So really exciting kind of different ways to think about inclusionary opportunities for students to engage with data analytics and data science. Next slide, please. So the last thing I will leave you with, I think I am perfectly at time, is thinking through as professionals what it means to educate the next generation and thinking through the difference between data science as a standalone, certainly still interdisciplinary program, or these opportunities to train individuals who are specializing in a particular field and bringing in those research methods and those data analytic skills and thinking through, again, what does it mean to collect data? What does it mean to ask questions? What is exactly a variable? So think through, offering a research methods course that's not for that's intended for a non-scientific student, or offering a data analysis course that is not embedded in methodology necessarily, but can provide individuals those skills. I will stop there. Next slide. Again, my name is Emily Dow. My email address should be up on the screen momentarily. There we go. I'm happy to answer questions. I, again, feel honored to be invited to talk with you all, and I'm impressed with all the great work that I've heard. So thank you.
Thank you. That was very good and right on time. I do kind of have one quick question for you, and then I know Dr. Shaya wants to make some concluding remarks. But as far as this idea of interest in data science, it's sort of a chicken and egg question. Is the prevalence of it driving the interest, or is the interest driving the prevalence? I mean, do you know which it is, or do you have a sense of that?
No, and I would actually say it from an educational training perspective,
right,
I think it varies from institution to institution. In so much because it's such an interdisciplinary program, you either have researchers who are recognizing I need to train people who have specialties in this kind of skill set, Or you have the specialties coming to the researchers saying, hey, can you help us train our students? So I think it depends on the institution. And I think those conversations, this is where really faculty need to talk to one another and deans need to support those discussions.
All right, very good. Let's bring Dr. Shaya back in for some concluding remarks. Before we go, we have a couple of minutes. Dr. Shaya, do you have some words you'd like to say?
Yes, absolutely. So let's see here. Here, am I on? Okay, perfect. So I do want to thank all the speakers for a terrific program, and thank you, Alex, for moderating this whole day of sessions. I do want to thank also, first and foremost, our funder, the National Institutes of Health, NCATS, and Dr. Curie, who was the project program officer, as well as Dr. Gersing. So these are very important thanks. These are the people who made this conference happen and made it possible. Of course, I want to thank again all the speakers and the Institute for Clinical and Translational Research at the University of Maryland, Baltimore, and at Johns Hopkins, as well as the Clinical and Translational Science Institute at Duke, where we had Dr. Boulware speak, as well as all the institutions of the speakers and their affiliations. So with this program, our goal was to talk about data science and social determinants of health. As you see, we have covered the spectrum of all the topics of interest. And I'm going to list them here, but I promise you that we're going to get back to you and zero in on each one of these, but in shorter sessions. So these might be only 50 minutes, 50 minutes for each one of these sessions throughout the course, perhaps of next year. One way or the other, you will hear back from us. So we have covered here the social determinants of health, the infrastructure of the National Coordinating Center, that's N3C. We have covered electronic health records, human data science, pharmacy data, social data, democratizing data, medical devices, digital health, mHealth, all the apps, social capital and social networks, machine learning and fairness issues related to AI and machine learning. And finally, we wrapped up with that infrastructure of education, because no matter how much we talk about these, unless we expand it to people who are not, in other words, under the tent, as we are, because we are interested in that topic, then we have not achieved our goal. And as you heard, starting with that can be an increasing awareness, but it has to also make its way into the didactic programs that we offer, even starting in school, high school, or even early in college. So this is important to have people become facile with the language, because we do not have a choice. All data is health data. And if we don't make it happen, if we don't develop a good understanding for it, people who do not have that healthcare interest, or perhaps that healthcare inclination at all, whether they be high technology companies, and not to malign them, but Google, Facebook, or others, and that's fair enough, but they are using our information, and that's fair because our information is available to all. However, we need to take charge, and we do need, it is almost our responsibility to be taking charge from the get-go. So with this, the message here is to keep moving forward with the translation and the dissemination of information by making sure that our data science approach is deliberate, and that it is, and that we have today over 1,000 people who have either registered or expressed interest in registering. And we are going to make all these materials available to you in recorded fashion. So you will have an answer to that. Any question that you might have asked, we will try to categorize them into categories and post them so that everybody has access to that additional information. And do keep in mind that major message out of this conference is to translate that information, make sure it is accessible to all, and democratize data science, and make sure that we pay attention to disparities. And with that, I'll hand it over back to you, Alex.
Dr. Chai, you have thanked, I think, everyone who needs to be thanked. So I won't belabor it any longer, except to say this was a very educational and I hope evocative and thought-provoking day. And as you mentioned, we hope to do it again in different forms coming soon. So thank you for being part of this. And this concludes our program for today. Have a great evening and a wonderful weekend.